blood, as does the stroke volume. So the stroke volume is the amount of blood that's pumped by the left heart for one circulation, one beat of the heart. So heart rate increase plus stroke volume increase, blood volume increase, that increases the overall cardiac output. Then you have, and the heart rate increases about 15 beats per minute. Then you have a decrease there in the systemic vascular resistance. And what that means is there is a relaxation of the smooth muscle, which causes vasodilation, or the vessels are widening in order to accommodate that increased blood flow. Because that is due to the fact that the progesterone is increasing, and the progesterone helps to keep the viable pregnancy. So that leads to an overall fall in blood pressure. If everything dilates, the blood pressure gets a little bit lower. And this occurs ultimately because the uteroplacental circulation is a low resistance circulation. So we want gentle flow to the baby. So everything kind of expands and opens up so that the flow is nice and smooth and a little bit lower. Then if we look down at the respiratory system, so you have increased tidal volume, increased VO2, and then an impaired ventilation, so a rise in that diaphragm as the uterus is pushing up on it. So your minute ventilation increases up to about 50%, primarily as a result of an increased tidal volume. And that tidal volume basically is your normal volume of air expelled and inhaled without any extra force. So it's just the normal breathing pattern. So if I have an increase in my diaphragm, it's pushing up on the space that my lungs are in, then it takes me a little more time to breathe. And so that can increase the amount of breaths that a woman takes. And then lastly, temperature regulation. So it's highly dependent on hydration and environmental circumstances. And I'll talk a little bit about what that means on some later slides, but nevertheless, staying in a tempo neutral environment is going to be what's best for the baby. Overall, there's benefits for exercise in pregnancy and really in all stages of life, because it does help to maintain and improve your cardiorespiratory fitness, reduces the risk of obesity and associated comorbidities, and results in greater longevity of life. So physical activity within pregnancy has been shown to benefit most women. So it improves and maintains physical fitness, decreases the incidence of cesarean and operative vaginal delivery, decreases postpartum recovery time, although there is limited evidence regarding that, and just enhances their psychological well-being. People like to move in general, and so to get a little bit of physical activity is a good thing ultimately. So what happens to the baby as we're exercising? So the heart rate increases. It can increase about somewhere between 10 and 30 beats per minute while the mom is exercising. You can also have a shift where it may decrease, and that's just because of different forces. So for instance, if I am powerlifting, so I have a vagal response where I bear down, sometimes that can affect the baby's heart rate to decrease it, as well as things like cord compression or fetal head malpositioning. So if the baby's head is turned in an odd direction when somebody's doing some sort of physical activity, that can also affect the heart rate. With vigorous exercise, especially during the third trimester, remember that's the trimester where the baby gains the most weight, the mom gains a little bit more weight to accommodate that. Infants are actually more likely to weigh 200 to 400 grams less than compared to the fetus of a woman who did not participate in those vigorous activities. For instance, intense running programs, high intensity interval training, or some weight training, powerlifting. There's no increase in fetal growth restriction, however. So overall, the fetus tolerates about 30-minute intervals of strenuous exercise in active and inactive pregnant women. The American College of Obstetrics and Gynecology, their committee came up with an opinion, and they reiterate that physical activity within pregnancy has minimal risk and has been shown to benefit most women, although some modification to exercise routines may be necessary because of the normal anatomic and physiologic changes as well as fetal requirements. So I will emphasize this several times: a thorough clinical evaluation and communication as well with your OB should be conducted before recommending an exercise program to ensure that a patient does not have a medical reason to avoid exercise. Women with uncomplicated pregnancies, they should be encouraged to be aerobically active and participate in strength and conditioning training before, during, and after pregnancy. So overall, regular physical activity, again, it improves fitness, helps with weight management, and reduces the risk of gestational diabetes in an obese woman. So when you're recommending an exercise program, you want to think about the 5 A's. So ask, advise, assess, assist, and arrange. And this really helps in aiding and developing the exercise plan. So communication, again, is key with the physician, because you could be an avid participant in a multitude of activities that are physically strenuous. So you want to have that communication with your physician prior to either continuing or starting an exercise regimen. Because you never know, there are things that you could be doing that you might want to avoid or adjust. And then there are things you think that you can't do that in actuality you can. So it's very important to have that dialogue. And then the prescription is individualized. So with that thorough clinical evaluation and assessment, you can individualize that plan for a healthy pregnancy and a healthy exercise routine. And the program development goal that we typically stick to is a moderate intensity exercise regimen for at least 20 to 30 minutes per day on most or all days of the week. Some women do tolerate 60 minutes. So if that is indeed the case, then you adjust for that 60-minute program. So just considering some absolute contraindications to aerobic exercise during pregnancy, I'll just mention a few. So incompetent cervix or cerclage, the cerclage is that stitch that they put within the cervical opening to avoid a premature birth, or if they feel like the cervix is weakened or it's thinned, they just add that in order to keep the baby viable. Persistent second or third trimester bleeding, premature labor during the current pregnancy, any rupturing of membranes, or preeclampsia or pregnancy-induced hypertension. Some relative contraindications would include anemia, poorly controlled type 1 diabetics. Type 2 and type 1 diabetics, you do have to worry about your sugars while you're engaging in physical activity. So you want to make sure that you have the right amount of insulin on board, that you make sure that you're eating before, during, and after said exercise. So it's just really important for those people to watch those things. And so for a poorly controlled person, you may not be able to control that as tightly as with someone who is controlled. When we talk about orthopedic limitations, so if they have an arthritic joint, and in pregnancy in general, your ligaments become a little bit more lax, so you do have an increased propensity to have some injury. So you just want to be mindful of those things and maybe adjust to where your orthopedic limitations play into whatever the exercise program is. So you want to think about that. And then poorly controlled seizure disorder and heavy smokers. So you want to assess, again, for a safe and unsafe exercise regimen occurring before the pregnancy in order to instruct the patient to avoid those activities that may jeopardize the health of the fetus. So again, communication is key with you and your physician to figure out what is best for you and the child. So pregnant women who were sedentary before pregnancy should follow a more gradual progression of exercise. So regular exercise before pregnancy, and those that have uncomplicated healthy pregnancies should be able to engage in those higher intensity exercises like walking, for instance, or like a speed walking or jogging exercise. And then high intensity in excess of 45 minutes can lead to some hypoglycemic events. So again, there is a need for adequate caloric intake before exercise or limiting the exercise session. Things like swimming are really great for the pregnant woman. When you're under the water, you're essentially weightless and you can do the moves under the water, and it creates a thermo-neutral environment for the baby. Yoga modified, Pilates modified. So of course, like the downward dog or laying on your belly is probably not the best thing to do. So we want to avoid those types of movements. And then strength training with modification. Things that you should avoid, so contact sports, anything that jeopardize you getting hit in the head or in the belly, activities with high risk falling, scuba diving. So we think, okay, I can swim, but I can't scuba dive. Why? That's really because the pulmonary circulation of the fetus is not developed. So if you think about it, the baby takes the first breath when they're outside of the womb. So their lungs are collapsed in utero, and so they can't filter the bubbles like we can filter them when we go deep sea diving. So definitely avoid that. Skydiving, and then hot yoga or hot Pilates. So this is what I was talking about before when I discussed in brief thermo-neutral environments to work out in. So a hot yoga or hot Pilates class can indeed raise your core temperature. And if I'm raising my core temperature, I'm raising the baby's core temperature, and those elevated temperatures can disrupt fetal development. So when we're thinking about assessment of activity, so there's been quite a few studies that have indicated that normal heart rate response to physical activity may be blunted. So I can't just watch my Fitbit to determine what my heart rate is when I'm pregnant. So things I think about are perceived exertion and the talk test. So perceived exertion is just that. How do I feel? Is it really, really light, or is it really, really hard? And then the talk test is essentially if I can carry on a conversation while I'm doing my exercise, and it's probably not too vigorous and I can continue that exercise. Warning signs to discontinue exercise while you're pregnant, so any vaginal bleeding, dyspnea before exertion, dizziness, headache, chest pain, calf pain, or swelling. So women, when we are pregnant, we are more hypercoagulable because remember that blood volume has increased, and so the blood viscosity is a little bit higher, it's a little thicker. So we do run the risk of blood clots. So you want to be mindful of that calf pain or that swelling, or even chest pain, dyspnea with exertion, shortness of breath with exertion. So those are signs. So briefly talking about nutritional guidelines. So for an uncomplicated pregnancy, women should include a variety of food, both within and among food groups, to assure that all essential nutrients are obtained. So small meals and snacks at regular intervals, attempting not to skip meals or wait too long to eat, and then high carb snacks before and after exercise. You want to make your fats count. So salmon, rainbow trout, non-hydrogenated oil, canola, soybeans. So essential fatty acids do help with fetal brain development and eyesight. So essential fats are key. Supplements, keeping up with your daily folic acid or prenatal vitamins, and then fluids, lots of fluids, about 2 liters, which is 8 cups essentially, of daily combinations of water, milk, juice, decaffeinated beverages, or soups. And then when we think about sports drinks, you want to choose something that has 6 to 8% carbohydrates. So like your run-of-the-mill Gatorade or Powerade for refueling of muscles and to replace fluid and electrolytes lost in sweat. You want to make sure you're limiting your caffeine, avoiding that alcohol, and then getting enough salt. So some folks are salty sweaters during exercise, so you want to be able to replace sensibly with the use of table salt, condiments, tomato, or vegetable juices and soups. Energy bar consumption, more carbs than protein is really key, and they are not meal replacement. So even if you are having those snacks before and after, you still want to make sure you're getting in your couple meals a day. And then just be safe. You and your obstetrician gynecologist will certainly talk about all the things to avoid and all the things that you can still do, but avoid raw meats, avoid unpasteurized cheeses and pâtés, and then avoid popular herbal supplements. So things like ginseng and echinacea. So pretty popular, but not proven to be safe in pregnancy. So you want to make sure if you are doing an herbal supplement that you discuss that with your physician prior to continuing with that or engaging in that.
2 minutes.
All right. NCAA guidelines. So there was a study with a sample of 92 female college students. So 62% reported sexual activity, 10% viable pregnancies, 15% male and female students between the ages of 18 and 24 reported experiencing pregnancy, and 48% thought they might be pregnant. Female college athletes, the complete opposite. About 1% of female athletes report pregnancy, as athletics decreases your sexual activity overall and increases the usage of contraception. Typically speaking, athletes want to play their sport, so they're going to do what they need to play their sport. And if they're not playing, they're typically in the classroom or they're studying so that they can continue to play their sport. So not surprising that this is the statistic. Gender neutral pregnancy and parenting. So the NCAA says there's no pregnancy discrimination. So your team membership, your playing time, your health benefits and scholarships not jeopardized. And then generally speaking, for health maintenance while you're pregnant, they follow the same guidelines that a non-student athlete would. So regular visits with their doctor, and then monitoring for safe practices overall before about 14 weeks of gestation. So for their high-level activity, again, guidance of their healthcare provider, athletic trainer, coach, using sensible and monitored training before 14 weeks. And then beyond that, that's when those physiologic changes really take hold. And so we want to adjust their activity for that overall performance, and eventually they may even have to sit out. So balance and coordination. Supine training is affected. So again, laying flat, they may need to lay on their side to do the activities. Salvage training and training programs like lifting, and then avoidance of training and events that increase the risk of abdominal injuries. And then lastly, just emotional support and confidentiality. So the NCAA came up with a model policy, which basically discourages such disclosure requirements for pregnancy, and that's for several reasons. So first, the student athlete may have the baby while she's off season, so there's no reason to really involve a bunch of people. She has the baby, she comes back, she plays her sport, she takes care of the child, the end. Secondly, about 10 to 15% of people spontaneously miscarry. So you either know that you're pregnant and you have that miscarriage, and so you want to be able to take that time to have those emotional feelings about it, or the student athlete may be pregnant, have the period, think nothing of it, and move on. And then lastly, there are still some places that allow for abortions. So you want to make sure that you're keeping things kind of closer to the vest, if you will, and when you're talking about it, because it's still her choice and it's still her partner's choice. So they want to be able to have that conversation in a private manner. And so to have to necessitate to the involvement of all the coaches and trainers is really unnecessary, and it makes it for more of a tough decision for them to decide what to do. The privacy is key. So in summary, athletic activity in a healthy, uncomplicated pregnancy is safe and allows for overall health maintenance. For those patients with a complicated history, a specific program will be discussed with their team of doctors to determine what is best. Moderate activity is okay, and activities are adjusted based upon the development of the fetus and changes to a woman's body. Pregnant athletes should maintain a healthy diet for their activity. And finally, the NCAA recognizes and supports the pregnant athlete, and the care is the same as for the non-student athlete. So, objectives: normal anatomic physiologic changes. We talked about benefits and potential risks of an exercise program, considerations and recommendations of the exercise program, exercise prescription and basic nutritional guidelines, and lastly, NCAA guidelines. Here are my references. Thank you very much.
Thank you, Dr. Kitt. Our next speaker will be Lisa Preston-Sue, presenting on postpartum considerations in the female athlete. I would like to remind all of our attendees to please use the Q&A function to ask questions, which will be answered at the end during our panelist session. And now, here's Ms. Sue.
All right, let me just get my share screen up. Okay, and okay, everyone can see that okay. Let's make sure. Can you hear me all?
Yes.
Okay, awesome. All right, so my name is Lisa Preston-Sue. I also go by Elizabeth, that's my given name. And I work in the Department of Rehabilitation at Emory. I focus most of my practice on wound care and hyperbaric medicine, but Dr. Taylor and I recently were working in the Women's Health Rehab Clinic, which we also both started a couple years ago. And that has since now been closed, but we are both very interested in rehab and women's health involving that. So I will start, but I'm actually going to put myself off video here, but I'll continue. There we go, okay. So for some inspiration, this is Alicia Montano. She's a middle distance runner. In June 2014, she completed the USA Outdoor Track and Fields Championships while she was 8 months pregnant. That's the picture down here in the pink. She gave birth a couple months later. And then a year later, in June 2015, she returned and then won the 800 meters final in the US trials and qualified for the World Athletics Championships in 2015. And then again in 2017, she ran the 800 meters while she was 5 months pregnant, which is this picture here. So that's awesome. And the next slide. This is our next inspiration. This is Paula Radcliffe. She's a British runner. She's won multiple marathons. In 2006, she took some time off from running, got pregnant, and then gave birth in 2007. And then she returned that year to marathoning, to the New York City Marathon in November, which she won the female division with an official time of 2:23:09. So for my talk, I might talk a lot more about running here and there, but really this applies to a lot of different athletes, whatever they like to do for exercise. But I like to talk about running because it's a very accessible activity for a lot of women. So my basics are going to be looking at some basic recommendations, and then what are some return to play issues that affect women who are postpartum, and then some myths that we might hear that we want to debunk. And because of the information we'll go through in the beginning, we'll probably know most of the answers to that. So first off, we're going to talk about the definition of a pregnant athlete. And I say pregnant here because sometimes people wrap pregnant and postpartum athletes together. So it's a pregnant female during any stage of pregnancy from prenatal to postpartum with an established pre-pregnancy fitness who chooses to continue participation in a regular physical activity program. It's also important because when you look for research studies or such, you might find more information on postpartum athletes if you look under pregnant athlete, just FYI. So for my purposes too, when a woman has had a baby or she's been pregnant, she is always going to be postpartum after giving birth, no matter if it's a month after or if it's 5 years after. Pregnancy changes a lot of things in the body, and that body is going to be a different athletic body afterwards. So you got to think about, you've grown a new human for 10 months and we need to have time to recover. We're inundated with lots of social media saying, you know, with celebrity moms, oh, we're getting back into normal after a month. But remember, everybody is different. We don't all have personal trainers. Athleticism doesn't necessarily predict faster return for everybody. So think about the postpartum body as a new normal. So pregnancy changes, Dr. Kidd already went over. I'll just quickly go through this again. There's that shift in the center of gravity anteriorly, which over time then results in that exaggerated lumbar lordosis. You can kind of see that in this picture here from the beginning to the end. Then there's that change in the mechanical loading of the lumbar spine because there's more counteractive dorsal forces needed in the back. There's stretching and weakening of the abdominal muscles. There's stretching of the pelvic floor because of the added weight. There's peripheral joint laxity during pregnancy and postpartum, especially if a woman is breastfeeding. And then after birth, those muscles are still weakened, stretched, and then the core is going to activate differently because those muscles are just different. So obviously, if the core is affected and a woman has been an athlete, it's going to affect how she's an athlete later after being pregnant. So this is a representation of how much the pubococcygeus muscle and the iliococcygeus and puborectal muscle, but specifically check out the 2 through 8 mark here for the pubococcygeal muscle. It's kind of the lighter red mark. You can see that on the first picture a little bit better than the other one. There's lots of stretching and strain on vaginal delivery on certain muscles. So especially the pubococcygeus, it stretches about 3 times the normal length during a vaginal delivery. Obviously, that can be a setup for strain. There can be injury, there can be avulsion, there can be nerve injury. So why exercise? Again, Dr. Kitt went through this. It optimizes cardiopulmonary fitness. It helps strength for improved tolerance of labor. There's less risk of gestational diabetes, for instance, and preterm birth. And then it also can help decrease time to achieve that peak athletic performance postpartum. But again, there is a wide spectrum of recovery. So how much exercise? And again, I know Dr. Kitt went through this, but I will go through a little bit more after this on some information on elite athletes too. So the American College of Obstetrics and Gynecology in 2015 said at least 30 minutes of exercise to help reduce backaches, constipation, and improve overall energy. And then it was revised a little bit more in 2018 to incorporate more evidence regarding the risks and benefits of physical activity and exercise during pregnancy and the postpartum. And that was just released in April 2020. The minutes can be broken up into smaller packets of time. 30 minutes is good. Some women can tolerate longer. That's fine. Walking, running, swimming, biking, some kind of non-contact sport is recommended. The Health and Human Services guidelines in 2018 helped people understand how much physical activity was needed for everybody basically in this country. And there's a federal advisory committee that was set up, and it was composed of researchers in physical activity, in health and medicine. And they put together a multifaceted analysis of all the available scientific literature. And then they put this out in 2018 as the Physical Activity Guidelines Advisory Committee Scientific Report. And it gave recommendations to the federal government on how much physical activity and sedentary behavior and health was okay. So this was nice because it divided the amount of activity needed for each group from prepubescent to teenagers to adults to older adults, pregnant women and postpartum women, people with disabilities. I think those were all the groups. And then from this information too, then the American College of Sports Medicine, for instance, and the American College of Obstetrics and Gynecology could also then update their older guidelines. So I'm not going to go through all of this information here. You can read that yourself. But the last one here, it says, women who are pregnant can consult their healthcare provider about whether or how to adjust their physical activity during pregnancy and after the baby is born. Now, to me, sometimes that's a little confusing because not everybody understands the recommendations. I think now in the last 5 years, it's been a little more clear, but even 5 years ago, even 4 years ago, I think some people were still kind of trying to figure out what was appropriate, and especially even for elite athletes. More women are having babies later in life. So if there are more women having babies later, then obviously women who are professional athletes are going to be in their 30s and 40s having their babies. Their motherhood and their careers are overlapping more. They want to know, when is it safe to go back? How much is okay? Can an athlete who's now a mother still be competitive? Every woman is different. In 2015, Kari Bo, who is out of Norway, got together with a group through the International Olympic Committee meeting to discuss research about exercising during and after pregnancy, because there is such a paucity of studies on pregnant and postpartum athletes. So I included the two references here. The first one is for planning pregnancy and who are pregnant, and then the part 3 is exercise in the postpartum period. And you can go through those a little more later when there's more time, but this gives more elite athlete recommendations. So in summary, in this section, the new recommendations are easier to understand, but not all providers understand all female athletes. So having an evaluation with somebody who understands is important, like a sports medicine person who works with women. Okay, let's talk about issues affecting return to play. There's back and pelvic girdle pain, urinary incontinence, diastasis recti, postpartum depression, and then other orthopedic and musculoskeletal issues. Those last two I'm not going to talk about for the sake of time, but there are definitely a lot of things that can be covered under there. With back pain and pelvic girdle pain, pelvic floor dysfunction was associated with pelvic girdle pain and low back pain. And pelvic girdle pain is just the sacroiliac joint and the pubic symphysis in general. So if there are up to 50% of women with these issues in pregnancy will have them postpartum as well. So it's important to address them as early as you can, so that keeps them active. This can be from delivery positioning. If it's postpartum, there can be wound healing issues. The joint and muscle laxity during pregnancy and after pregnancy can be affected or can affect this. And then the core with the weight gain and the stretching of muscles and such, it can be affected. Now, one of the important things that we have to remember, and I'm sure that Blair will talk about this after me, that the pelvic floor is part of the core. You can't forget that part. That affects everything else in that cylinder of your core and how you exercise. So Dr. Taylor will also talk about urinary incontinence a little more, so I'm going to just rush through this. Urinary incontinence in a postpartum woman is common, but it's not normal. And this is related to pelvic floor weakness from nerve injury. It could be from muscle injury, surgical scarring. There could be a poor core to begin with, even before pregnancy, and it's just worsened after pregnancy or during pregnancy. Kegel exercises can be helpful, but not every woman knows how to do them correctly. They should be evaluated by a pelvic health therapist, and they can then decide if the Kegel exercises are appropriate or something else needs to be done. But I recommend everyone get evaluated. Diastasis recti is the separation of the rectus muscles because that fascial joining in the middle splits in pregnancy to allow for the gravid belly to grow. It's very common in pregnancy and usually resolves on its own. It's usually improved with appropriate exercises that target those deep core muscles, like the transverse abdominal muscle. If that space between the left and the right rectus muscles are about a half a finger wide, it's really not that severe. It's probably going to resolve on its own, or you may always have a little bit of a space there that may not affect the core. But if it's about 3 or 4 fingers wide, then that can signal a weaker core, and then there's a risk of ventral hernia development. And that's where I would say talk to a pelvic floor PT or a regular physical therapist, and then they can make a recommendation if you need to go to a surgeon. So I included this because this is not a physical thing, but it can affect the physical things you do. It's important to take care of everything. And physical activity is so important for a part of overall well-being. Postpartum baby blues are common in the first 2 to 3 days after delivery and last up to 2 weeks. And that's the mood swings, the crying spells, anxiety and difficulty sleeping, just trying to adjust to this new thing happening in your life with a new baby. The postpartum depression is kind of like the baby blues, but it's more intense and can last longer. It can interfere with caring for the infant. It can interfere with how you take care of yourself. It can interfere with other daily tasks. It develops within the first few weeks after giving birth, but it can start during pregnancy and even up to a year after birth. So be aware of that if you're screening patients. Causes can be changes in hormone levels after delivery, sleep deprivation, which messes up everything in everybody's life, no matter where you are in your life, anxiety with having a new family and the help needed, sense of identity and control might be lost, and then lack of social support can also affect it. Okay, let's talk about our myths. I have 6 myths. I'm going to go through this quickly again, and then I'll be about done. So the first myth is avoid exercise or intense exercise, depending on who you talk to, until 6 weeks postpartum. And the answer is no, 6 weeks is really arbitrary. 6 weeks is often associated with that postpartum follow-up with your obstetrician. And exercise, when you start and how much, really depends on recovery. If you've had a C-section or not, if there have been other surgical issues, if the wounds are healing, if there are other complications like infection, like mastitis, if there are cardiac issues that happen, like preeclampsia or something before, during the delivery process. Lack of sleep, obviously, that can be huge. The needs of the infant can also affect how much you might exercise. If you have an infant who is really ultra fussy and you need to care for them more, or you are up more and you don't get much sleep. If you have a NICU stay, that can be really stressful. If you have a baby with special needs even. Take it very slowly. Don't expect to get back to the previous baseline. And this is a new normal, and try to delegate responsibilities if you can. Exercise affects breastfeeding and dries up milk. Okay, breastfeeding itself may only really be affected if you spend hours and hours away from your baby training. Say if you're training for a marathon or something, you're not going to be able to breastfeed as often. So the act of breastfeeding. Pumped milk is important here, but the actual production of milk is a feed-forward system. So if you have nipple stimulation from the baby or a breast pump, you're going to continue to make that milk as long as you have enough calories and enough hydration. You're burning more calories making milk. You're burning more calories exercising. You want to increase the caloric intake and the hydration to make sure that you can make the milk and you can exercise effectively. Lactation is a huge calorie burn. Myth 3, leaking urine when I exercise is normal after having a baby. Well, like we said before, it's common, but it's not normal. And I would say this is where you get an evaluation from a pelvic floor therapist and then decide if exercises are helpful or if it's something more severe. Myth 4. The split in my stomach muscles won't ever heal and need surgery. This is the diastasis recti, and we already talked about can be treated with those tailored core exercises. If it's really wide, then there's maybe a risk of hernia development, and we need to have a pelvic health therapist evaluate that. Pregnancy changes anatomy, such as the location of certain organs and posture, and thus postpartum athletes can't be as good as they were before pregnancy. And I say, no, they can be better. Our bodies don't go back to our pre-pregnancy bodies. That's totally expected, but they can be just as athletic or better. It all depends on how the body is healing and then easing into training appropriately. And then myth 6 kind of goes along with this. An elite athlete will recover faster than other athletes or non-athletes. Possibly, and this is what I've been harping on the whole time. Women who have had regular exercise during pregnancy generally recover faster than women who do not, but it depends on what's happened during, like if there's been a major surgery or some other medical issues. So give yourself some grace to recover. You created and birthed a new human, and healing from this needs some time. Some women will get back to exercise more quickly, say in a month. Some women will take longer than that. So some benefits, postpartum exercise, obviously weight loss, helps with postpartum depression because it helps with the overall well-being. Even if it's a 5-minute walk in the sun for every day of the week, that's better than nothing. It helps with overall fitness. And then the one thing I really like is relearning how to use your body. Sometimes if we kind of have this reverse or kind of a setback, kind of a rethinking of how we use our body, if we can make it better than how we were using it before. So having an appointment with a physical therapist is important. Even if you think you're doing fine and you're not having any leaking or your pain is fine, just having an evaluation is great. You want to try to go to a sports clinic if you can who sees women. Healing is important to minimize those issues with the pelvic floor. And then sleep, obviously, which is, I know, really, really tough for some people, but even a nap here and there can be very restorative. You want to ease into the activity and listen to your body. Try to pump or nurse before exercising to lighten that breast weight to be more comfortable. And if you're a runner, you could bring the baby with you. If the baby's about 6 months old, you can get a running stroller. You want to make sure that that stroller is the correct height. Some strollers have attachments for car seats. So infants with some decent head control and a flat surface might be okay in a stroller too. All right, and that's all I have. Thanks.
Thank you, Dr. Preston Sue. Next, we have Yogita Taylor presenting urinary incontinence versus the female athlete.
All right, can you hear me and see my slides?
Yes.
Yes.
All right, good morning, everyone. Let me start my video as well. Hi there, I am Yogita Taylor. I'm a physician at Emory. I have significant interest in women's health. Like Dr. Preston Sue mentioned, I also do wound care and hyperbarics, and we started a pelvic pain and women's rehab clinic here at Emory. I'm actually going to be transitioning to primarily working with pelvic pain outside of Emory, and I'm excited to talk to you today about urinary incontinence. Now, it may not be the most exciting topic, but I want to make this interesting, and we're going to have a little bit of participation on your guys' end. So make sure you guys see the Q&A session so we can communicate a little bit. Alrighty. So no financial disclosure. All right, so we're going to start off with a little pop quiz. And if you were listening to Dr. Preston Sue's lecture, you may have the right answer. All right, so urinary incontinence is considered to be normal for. Okay, so we have an elderly lady, maybe in her 60s or 70s. And we have a pregnant woman. She looks like she is likely in her 3rd trimester. We have a young mother, looks like she has 2 children, one toddler age and one maybe newborn age. And the last one is a young female athlete, looks like a track runner. All right, so does anyone have an idea of what the answer could be? And again, please feel free to use the Q&A to answer. I'll give about 20 seconds or so. I'm not seeing anything come through. Let's see. There we go. All right, we got a few answers. Okay, I have a answer C. A couple people, it's Leslie and Judy, have said none of the above. Any more guesses? All right, and we do have a winner, so the answer is none of the above. So like Dr. Preston Sue mentioned, urinary incontinence can be normal. It can be normal for the postmenopausal lady, a pregnant lady, a postpartum lady, as well as a female athlete. However, it is not considered to be normal. So we're going to define urinary incontinence. It's by the International Continence Society, it is any involuntary loss of urine, and that can even include slight leakage. The distribution is that urinary incontinence impacts approximately 25 million Americans. Approximately 1 in 2 women and 1 in 4 men. However, these numbers are a little bit misleading because urinary incontinence is very underreported. There's a lot of stigma related to urinary incontinence, leading to embarrassment, as well as there's lack of knowledge of, hey, is this normal, not normal? And people may not be more forthcoming in sharing that they have urinary incontinence, or they may have a fear of how this is going to be evaluated and treated, as well as impact on their day-to-day life, including sports. So a number of risk factors associated with urinary incontinence. Age, typically the older the age, there's a more likelihood of urinary incontinence. Obesity, parity, which is the number of children that you might have. So as you have more children, you have a higher risk of urinary incontinence. Mode of delivery, whether you had a vaginal or C-section, can affect the risk. Family history of urinary incontinence is something important to look into. Race and ethnicity also play a role. It's more commonly seen in white females as compared to African American or Hispanic females. Smoking also increases the risk of urinary incontinence, and there are certain medications out there, diuretic medications, even some antidepressants and sleep aids, which may increase your risk for urinary incontinence. And for our talk, we're going to kind of focus more so on the high impact activities. And high impact activities are ones that we would describe as you are, you have both feet off of the ground. So jumping, running are considered to be high impact activities. Okay, so the impact of urinary incontinence. So it's not something that you want, and urinary incontinence is more of a symptom rather than a diagnosis in itself. It's a symptom of something else going on, and it can also lead to other issues. So on the medical side, risk of candida infections, which is yeast infections, risk of cellulitis, infection of the skin, pressure ulcers can also occur due to urinary incontinence due to the moisture breaking down the skin, sleep disturbances. So if you're having incontinence in the middle of the night, it's going to affect your sleep. Risk for urinary tract infections, or urinary incontinence may be a symptom of a urinary tract infection. Higher risk for falls and fractures, again, more so in our elderly population. And there's also significant psychological impacts from urinary incontinence. Depression, low self-esteem, sexual dysfunction, as well as withdrawal from sport and activity. So again, the amount of urinary incontinence may cause people to feel withdrawn, whether from their social circle or from their activity, and they want to try to minimize that social embarrassment, or even they feel that if they don't participate in the sport, then the urinary incontinence will go away. But that doesn't have to be. All right, so there's multiple types of urinary incontinence. We're going to highlight the 4 right here. So there's stress urinary incontinence, which is weakening of the urethral sphincter, and it's secondary to, if you see right here, this is kind of a schematic of the pelvic floor muscles, and they kind of go hand in hand. So your pelvic floor muscles are made so that they are coordinated to contract in order to prevent you from urinating, and as they relax, it allows for the urine to pass through. So when you have weakening of the muscles and there's extra stress on the bladder, the muscles aren't able to kind of hold everything in place so that your sphincter is contracted. You have urge urinary incontinence. So that is when you have more irritation or even spasms of the bladder that is causing you to kind of feel that you need to empty all the time, and you have this overwhelming urge to urinate, even if the bladder may not be as full as you might feel. And the third one is the overflow incontinence, often due to some kind of blockage downstream from the bladder. It could be at the urethra, it could be kind of right at the outlet, it could be a mass, it could be a stone, it could be a number of things. And then there's reflex incontinence, where the nerves that are sending the signals to your brain to communicate that, hey, we have a full bladder or not full bladder, there's a disruption in that, leading to incontinence, because again, your nervous system isn't communicating with your musculature as well. For our purposes, we're going to focus more so on stress incontinence today. All right, so a little bit more of a definition about stress incontinence. So again, leakage of the urine due to that increased pressure on the abdominal, intra-abdominal pressure, and not necessarily with the contraction of the bladder. So these increased pressures can be cough, sneeze, laughing, or exertion, such as with the sport. And like I mentioned before, so you have your pelvic floor muscles right down here, which pretty much act like a hammock. And I'll show you a little schematic of that in a future slide. And the muscles have weakened, and that leads to decreased ability for the urethra and the bladder neck to close. And therefore you have that leakage of the urine. Okay, so this is a study done in 1994. It was published in the Journal of Obstetrics and Gynecology. It was more of a questionnaire for 156 elite college varsity athletes in a large state university, kind of similar to Emory. The mean age of these women was about 19.9 years old. All women were nulliparous. That means they've never had a baby. And about 28% reported urine loss during their sport. And they kind of broke it down based on what sport they were involved in. So 67% were involved in gymnastics, 66% basketball, 50% tennis, 42% field hockey, track was 29%, swimming 10%, volleyball 9%, softball 6%, and golf was 0%. And again, if you consider how, when we talk again about the impact related to your sport, golf really has minimal impact because your feet are always towards the ground, versus gymnastics when you're doing high level jumps and other maneuvers. A similar study was done in 2018, published in the Journal of Pediatric Urology. This one looked at younger women. So these are high school athletes, and they looked at 44 female high school athletes, and it was another questionnaire. And in this population, it was a little bit higher, 34.15% reported some urinary incontinence. And in this study, they looked at more so how much, how active they were throughout the year. So the athletes who competed all 4 seasons had a higher incidence of urinary incontinence during sports, but also they also looked at outside of the sport. So things like laughter and activities of daily living, your day-to-day activities. They also had some increase urinary incontinence when you compare to the athletes that participated in less than 4 seasons. And they also found that the urinary incontinence was associated with voiding more than 6 times per day. And another study, this one's from 2018 in the International Urogynecology Journal. This was more of a review, so a little bit more of a impact from this article because it looked at 22 studies, and the total women here were 7,507, age range from 12 to 69. And looking at they looked at the incidence of urinary incontinence, and it varied from almost 6% to 80% depending on the sport. So this is something that we are seeing kind of across the board, that your higher impact activities do tend to lead to a higher risk for urinary incontinence. Now, another pop quiz. So the pelvic floor muscles, which again we talked about briefly, are part of what muscle group family? So feel free to comment. Any guesses? All right, so for the sake of time, I'll give you the answer. Yep, here, I forgot one, so you are correct, Emily. So it is the core muscles. And again, when you're thinking about the core muscles, you know, when you're an athlete, you know, core is very important in training when you're thinking about gymnastics and things like that. So the question is, why are these women who are athletic, strong, having weakness of the muscle system? So let's kind of go over the components of the core. So the abdominal muscles are probably the most popular muscles that we talk about when we are talking about the core. So they're made up of multiple groups. So you have the rectus abdominis, that's the most superficial layer. That's the layer that everyone sees and talks about. That's your 6-pack. You have your obliques, which are your internal and external obliques, and then your transverse abdominis, which are the deepest muscles. And those are actually the most important muscles when you're talking about the core. And the core muscles are important to help with posture, stability, and coordinating with the lower extremity muscles for activity. Then you also have your spinal muscles, again, made up of multiple different layers of muscles, with the multifidus being the most important for posture. And then you have the pelvic floor, which is the floor of the core. And as you can see in this little schematic right here, it kind of looks like a little hammock. And this hammock is composed of multiple muscles. So the levator ani is a group of 3 muscles: the pubococcygeus, pubovaginalis, puborectalis, and iliococcygeus, sorry, 4 muscles, as well as the iliococcygeus and the urogenital diaphragm. And they make up a large network of muscles that will hold your bladder, your uterus, your intestines, and if you're pregnant, you have extra weight on there with the gravid belly. So it's a very, very important muscle group, but sometimes it is overlooked. And this is another schematic looking at the network of the pelvic floor muscles. We'll focus more so on the right side, which is the female muscle. So if you're kind of trying to orient yourself, so imagine this person laying on the floor with their feet outward. So their feet are coming out of the screen. This area here is the top, kind of where the pubic bone is. This is the bottom where the buttocks is. This is their right side, and this is their left side. And you can kind of see part of the layers of the pelvic floor muscles. And again, these pelvic floor muscles are very important with continence. And you see how they kind of surround the anal area as well as the urethral area. And it's a very complicated network of muscles. And so there needs to be a coordination of these muscles in order for the urine and bowel to go through. And again, if you think about if you think about pregnancy and delivery, these muscles get strained and changed very quickly. So these are very important muscles to think about. And again, even non-pregnant or postpartum patients, imagine kind of the constant abdominal pressure that they may be getting if there's significant high impact activities going on.
2 minutes.
Okay, so other factors that are related with urinary incontinence in athletes, not as great of data out there, but I'm just kind of presenting it. Eating disorders, which may be common with athletes. So just kind of look at this one study that had stress urinary incontinence, a little bit higher proportions than with athletes with eating disorders, with close to 50% compared to the healthy athletes, which was just under 40%. It's questionable if there's a lack of energy and nutritional factors to build and strengthen the muscles, as well as some increased abdominal pressure related to repetitive vomiting. So again, the repetitive vomiting will add intra-abdominal pressure. Also related to that is hyperestrogenism. So again, hormone levels can be impacted by the amount of exercise that you do. And so there's a question of if that also affects the pelvic floor muscles, as well as related to the eating disorders, if depending on how severe it is, if that also affects your hormone levels. Okay, so basic evaluation of urinary incontinence. So the history is going to be the most important. We're going to learn about, we want to know about when did this urinary incontinence start? How long does it last for? How severe is it? You know, how much urine is coming out? How frequent are you leaking? Is it just during sport? Is it just during cough? You know, other urinary symptoms. Is there burning? Is there any you know, burning with urination or any signs of urinary tract infection? How much fluid are you drinking? Are you drinking excess? Are you drinking a lot at nighttime? What exercise and activity are you doing? Other systemic symptoms, you know, fevers, chills, things like that. They may ask you to do a voiding diary, which kind of, you give them a schedule of, hey, when am I going to the bathroom? When am I having leaking? What am I drinking? And the impact of quality of life on of the urine from that. Physical exam, so they would do an abdominal exam to test for any masses or pain, neurologic exam to see if there's any nerve-related issues, and then a pelvic exam looking for atrophy, inflammation, any masses, pelvic floor strength, and sphincter tone. Bladder stress test is when you stand comfortably with a bladder full, and then the examiner will ask you to kind of cough Valsalva, and we'll try to see if there's any leakage of urine, and that has a predictive value about 78 to 97%. Post-void residual is when they have you urinate completely, and then we see how much is remaining in there to see if you're emptying completely. Urinalysis to check for urinary tract infection or any other issue. And questionable urodynamic study, it's more an invasive study to see how well the bladder and sphincter are filling and releasing urine, but that's not typically done. And treatment. So the big important part of treatment is recognizing that there's a problem, that this is not normal, and making some lifestyle modifications, smoking cessation, reduction of caffeine and alcohol, kind of avoiding excessive fluid intake, especially before training and competition, and then voiding before training and competition. And an important part of treatment is going to be pelvic floor physical therapy. And again, it's not just Kegels. And I'm going to let our next presenter, Blair Green, go more into the physical therapy option. Medications are out there, but may not be specifically appropriate for our athletes. And then surgery for more of urinary tract infection that's really not responding to conservative therapy and really bothersome. So summary, urinary incontinence is common, underreported in women, especially young female athletes, but that does not mean it is normal. Most common cause of incontinence in athletes is stress urinary incontinence, and this is associated with high impact sports. Pelvic floor muscle training is important first-line treatment for female athletes with urinary incontinence. And importantly, there needs to be a greater awareness of athletes in their professional team for the complaint of urinary incontinence so that there can be appropriate identification and treatment. All right, and that's it.
Thank you, Dr. Taylor. And next we have Blair Green speaking on pelvic floor physical therapy.
Hey, good morning. I just need to share my screen real quick. Thanks everyone for being here today. We're going to talk a little bit, we're going to bring it home in terms of pelvic floor rehabilitation and in the pregnant and postpartum athlete. For the sake of time, a lot of what I was discussing, it has already been said, so I'm going to try to go quickly through the stuff at the beginning so we can kind of get to the meat at the end, which is more how do we take a woman back to exercise after pregnancy and some pelvic floor considerations. So a little bit about me and why I love talking about this stuff. I'm a physical therapist. I'm here in the Atlanta area, just north of Atlanta in Dunwoody. My practice is called Catalyst Physical Therapy, and we specialize in the unique needs of women. So we work with a lot of women, both during and after pregnancy. We see a lot of athletic women from recreational athletes all the way up to more elite athletes. Last year, I co-authored a book, Go Ahead, Stop and Pee, Running During Pregnancy and Postpartum, with Dr. Kate Mahevik-Edwards, who is one of the keynote speakers today. So make sure you get a chance to listen to her as well. But most importantly, I'm a mom. I have a 12-year-old daughter and a 14-year-old son, and I did my best to stay active during and after both my pregnancies and still stay active today. So I really believe in practicing what you preach, and a lot of my staying active is to help them turn into healthy teens and adults as well. So the first thing I wanted to say was congratulations, you did it. Whether you're pregnant or you recently had a baby or your kids are a little bit older, if you're listening to this talk, you probably have some interest in pregnancy and postpartum. And I always like to remind women that pregnancy, it's like running a marathon. It's 40 weeks on average of growing another human inside of you. And then we are either pushing that human out of us, or in the case of women who have C-sections, it's a major abdominal surgery to birth that baby. So the body is undergoing tremendous change through the pregnancy process, through the birthing process, and then through the postnatal recovery. So make sure you take a minute to congratulate yourself, give yourself a little bit of grace, and know that you did an amazing thing, and your body is going to thank you for it when you continue to get yourself maybe back where you want to be or back to an active lifestyle. I have a couple myths I wanted to dispel in this talk as well, so we'll go through. I just have three, and I think a couple of them look very similar to what we saw earlier. But the first myth is that exercise during pregnancy is harmful to the baby and will cause lifelong problems for my abdominal muscles and pelvic floor. Second myth, now that I am pregnant, I can expect to leak urine for the rest of my life. And the third myth, diastasis recti can only be cured with surgery. So hopefully by the end of this talk, you will see that we can dispel all three of these myths. Just some quick statistics, and I know we've seen a lot already this morning, but 1/3 to 1/2 of all women will experience pelvic floor dysfunction in their lifetime. So that's a high number. What we know is that while pregnancy is not the only reason women experience pelvic floor dysfunction, it is a primary risk factor for pelvic floor dysfunction. In addition, vaginal delivery is another risk factor for pelvic floor dysfunction. But just because you have a C-section, it does not mean that your risk is zero or that you will not experience symptoms of pelvic floor dysfunction. If we look specifically in a population of athletes, there were several studies. The one I really liked was in 2016. There was an interview of over 300 triathletes, and these athletes span from amateur athletes all the way up to elite level triathletes. And they found that in that group, 34% of them were dealing with urinary incontinence, and 28% of them were dealing with anal incontinence. And I believe another group of them were also dealing with both urinary and anal incontinence. And these were women who maybe had babies, maybe have never had a baby, or have never been pregnant. So it was a big mix. So what we found was that this is very common amongst all classes of athlete. And urinary incontinence is the most common impairment among female athletes, between 15 and 73%. So depending what study you read, there's a very wide window there. And this is not just common in women who have babies. We can see that 28% of college athletes complain of urinary leakage as well. And in long distance runners, in 62% of long distance runners who complained of urinary incontinence, not all of them had children. So they did a study, they looked at long distance runners, and they found that regardless of parity, which is whether or not you've had a baby, 62% of those runners were complaining of urinary incontinence. So while pregnancy is one factor, it is not the only factor. So before we can really talk about how do we rehab the pelvic floor, we need to understand what is the pelvic floor. The pelvic floor is 3 layers of muscle, and they're situated at the bottom of the pelvis. So it also includes the soft tissue around them. If you think about the way they attach from the back of the pubic bone to the tailbone, and then they fan out to the sit bones. So they create a hammock-like structure. And what that does is it allows the muscles to provide support for the pelvic and abdominal organs. In addition to the support role, as we've been talking about, these pelvic floor muscles also play a role in the opening and closing of both the urethral and the anal sphincters. They play a role in sexual function, including arousal and orgasm. And then the one thing I love to talk about is their role in postural control and core stability. So what's important to recognize about these muscles is that they are primarily what are called type 1 muscle fibers. This means they are endurance muscles for the most part. So the pelvic floor muscles are always active at a low level, supporting our organs, judging our movements, and reacting before we move. So whether we're going to lift our arm or our leg or twist or turn or bend, these muscles are going to contract before we even do any of that. They're constantly judging our movement. But 30% of the muscle fibers are type 2, meaning these are muscle fibers designed more for explosive and quick movements. So they are able to respond to quick things like jumping, running, any kind of impact loading that a lot of athletes are doing in sport. And finally, a role of these muscles is to balance intra-abdominal pressure. So what that means is anytime the pressure in the abdomen goes up, the pelvic floor muscles are responding to that. So this could be something as simple as a cough or a sneeze, but it could also be something like lifting a weight or picking up a baby or even jumping or running. So there's different types of sports, and the pelvic floor is designed to withstand all of these different types of activities. So how does the pelvic floor work? Well, I'm going to highlight just kind of 2 components for the purpose of this talk. The first being the role of the pelvic floor in core control. So we already talked about at length how the pelvic floor is part of the core. It makes up the bottom part of the core. But the other muscles in the core, and all of these muscles, while they work individually, it's most imperative that they work together as a team. These include the deep abdominal muscles, the deep low back muscles, so they make up the front and the back of the core, as well as the diaphragm. The diaphragm makes up the top of the core. So all 4 of these muscle groups create this canister effect that are working to anticipate movement and working to balance intra-abdominal pressure. If we look at that specifically for continence control, so how are we keeping ourselves from leaking urine, the pelvic floor muscles are helping to balance the intra-abdominal pressure and the urethral pressure. So what that means is every time there's an increase in intra-abdominal pressure, the pelvic floor muscles are contracting to help increase pressure around the urethra. When the intra-abdominal pressure and the urethral pressure are equal, we can maintain continence. If the intra-abdominal pressure is too great, or the urethral pressure is not great enough to counteract it, that's when we deal with things like urinary leakage and other problems that we'll discuss. So how does pregnancy affect your pelvic floor muscles? Well, we talked about this a little bit, but what's important to remember is that as pregnancy progresses, the body is changing. The pelvic floor muscles lengthen because they have to adapt to the growing uterus as the baby grows. In addition, there's a lot of different hormonal changes that occur in pregnancy, And one of the things that happens because of these hormonal changes is what's called ligamentous laxity. So the ligaments in the body actually become more loose. This is designed so that women can give birth. This allows the pelvis to widen a little bit and allows the baby to be able to be delivered through the vagina. But as a result, it puts increased demand on the pelvic floor muscles to maintain control. Finally, there's weight gain during pregnancy. With weight gain, ground reaction forces are going to increase. So every time the foot hits the ground, the force down is going to create an upward force through the body. The more force down, which is what happens when we gain weight in pregnancy, is going to create more force and therefore more load on the pelvic floor. So as a result, increased length plus increased load will result in greater demand on the muscles. So the pelvic floor muscles are working much harder during pregnancy. Some other things that can occur, and we talked about some of these already, but two other things I want to bring up besides the things on the list that have been previously discussed are pelvic organ prolapse and also the idea of birth trauma. So pelvic organ prolapse, this occurs when there's a herniation of either the bladder or the uterus and sometimes the rectum into the vaginal wall. So there's a weakness in the vaginal wall that creates this relative herniation of these organs into the vagina. This can lead from anything to discomfort, a little bit of pressure. In more severe cases, the organs can actually, what you'll see is the vaginal wall will actually sort of like prolapse out of the body. And so sometimes you can kind of see a bulge there. For many women, it can be painful or at a minimum uncomfortable and make them not want to exercise. It's something that we really can help in more mild cases mitigate the symptoms with physical therapy. The other thing I do want to bring up is birth trauma. So in up to 1/3 of vaginal deliveries, something happens called levator ani avulsion. What this means is that the levator ani muscles, or part of the pelvic floor muscles, actually tear off the back of the pubic bone. So if there's a tear in a muscle, just like if you were to tear your rotator cuff muscles or strain your hamstring, that's going to create a relative muscle weakness that needs to be rehabilitated. So when we start to think about how do we rehab the pelvic floor, we need to think about it just like we would rehab any other muscle in the body, because the reality is these pelvic floor muscles are just muscles, and pregnancy and childbirth are really like going through an athletic event where we're putting a lot of strain on these muscles. All right, so here's our myth buster. You do not have to stop exercising during pregnancy. In fact, the American College of Obstetrics and Gynecology recommends up to 150 minutes a week or more of exercise at a moderate pace. You can continue anything you were doing prior to pregnancy as long as you're being monitored by your OB, you're not experiencing any bleeding or any other of the contraindications to pregnancy, and you feel that you're being safe. This isn't a time to maybe start new stuff, but if you were running prior to pregnancy, you absolutely can continue running during pregnancy. Research shows that pelvic floor muscle retraining can reduce the incidence of stress urinary incontinence postnatally, and it can also improve the symptoms of mild to moderate pelvic organ prolapse post-pregnancy. Pelvic floor physical therapy also reduces symptoms of pelvic girdle pain. It helps women who are having painful intercourse following childbirth. So there's a lot we can do with PT to get you back to an active lifestyle and feeling like yourself again. And then finally, looking at the core itself, so that includes the pelvic floor, as well as the diaphragm, the abdominals, and the low back, really can help improve the integrity of the abdominal wall and reduce the symptoms of diastasis recti, and in many cases, prevent a surgery. So what is pelvic floor physical therapy? You've been hearing about this for the last hour. It is specialized rehabilitation, and it's targeted toward the muscles of the pelvic floor and associated structures. The big take home from my talk today is that all postnatal women should be assessed by a pelvic floor physical therapist. We can look at things very differently and from a different lens than maybe a physician would. So we're looking at what's actually going on with your muscles. How are they functioning? How are they working together as a group? And how can we maybe change that or guide your return to activity post-pregnancy? In an ideal world, this takes place between 4 and 6 weeks after delivery, although certainly there are reasons why it might happen sooner or later. And even if you're a year out or 2 years out, it's not too late to have an assessment by a pelvic floor physical therapist. Like I said, we're mostly going to be focused on your musculoskeletal health, and this will include not only the pelvic floor, but also the hips, the spine, and the abdomen. So in most cases, women who are coming to physical therapy may only be seen for 2 or 3 visits just to get themselves moving in the right direction. But then there will be certain cases where a longer course of care will be required. And a lot of that's going to depend on what's going on with you and your individual goals. So this is never a prescription in terms of everybody's getting the same thing. It's a very individualized process. Every woman is different and every pregnancy is different. So it's important that you know what exercises and what timeline are best for you. Here's just a checklist, and I'll leave this up here. I know the slides are going to be sent, so if you want to come back and look at this, you can. But this is showing different signs that you may have pelvic floor dysfunction. So I would just go ahead and take a second to glance at it, and then we're going to move on. Okay, so you've just had a baby and you want to recover your pelvic floor. Where do we start? So I'd like to look at this in a phased approach, and there were actually some guidelines posted last year by a group out of the UK where they looked at postnatal return to run guidelines. So this was specifically running, but we can use it for all athletes in all sports. If we look at phase 1, I'd like to call this rest and recover. So this is really the first 4 to 6 weeks. And like we said, there's a little bit of time involved with this, but it's not a hard stamp that when you hit 6 weeks, you can go, or when you hit 4 weeks, you can't. It really depends on the type of pregnancy you had and the type of delivery you had. What's most important to remember is you can't just pick up where you left off. So whether you exercised up until the day you delivered, or you stopped the minute you found out you were pregnant because you felt like that was what was best for you, you can't just say, well, the last day I exercised, I went out and ran 5 miles. So the first day I decide to exercise, I'm going to go out and run 5 miles. Your body's not the same. It's not necessarily better or worse, but it's different. So I like to really focus just on some gentle movements of the pelvic floor and of the hips and spine to make sure that the body can recover. This is also a time when you're probably not sleeping much, and you're getting used to having a new baby at home. So your life is very different, whether it's your first child or you have other kids in the house. I recommend doing just what I call submaximal pelvic floor contractions. So we're going to talk a little bit about what Kegel exercises are and what they aren't. And with that, doing some deep diaphragmatic breathing. So like I said, that diaphragm is the top of the core, and we're going to talk about this as well. When we have good breathing mechanics and when we use our diaphragm well, that helps our pelvic floor works better. It helps our abs work better. So during the first month to month and a half after delivery, the best thing we can do for our bodies is deep breathing. It's going to help all these muscles recover a little bit more quickly, and it's going to help us with blood flow and oxygenation to really just get ourselves feeling a little more back to our postpartum selves. So like I mentioned, the diaphragm's working in phase with the pelvic floor to coordinate core control. So what's happening is as the diaphragm contracts down, the pelvic floor muscles lengthen. As the diaphragm relaxes when we exhale, the pelvic floor muscles and the abdominal muscles contract. So they're working in what I call a piston-like manner together. This movement is very, very coordinated. With pregnancy, there's a lot of changes in posture, and especially in the rib cage. Later in pregnancy, the ribs really start to flare as the uterus grows. And so it takes some targeted retraining of the muscles and the tissues in this region to get that alignment back where it needs to be. We know that better alignment is going to allow us to use our pelvic floor muscles better. So the first thing we can do to help our pelvic floor is help our diaphragm. And a phrase I like to use is blow before you go. So what that means is before you do an activity, think about your pelvic floor, take a breath. You're going to take a big breath in. You should feel your ribs moving up and out and your belly and abdomen expanding. And then as you exhale, you should feel your abdomen contract. Your ribs are going to move down and in. At the end of that breath, that's when you want to feel your pelvic floor contract. So what I want you to think about, it's like you have a little pea or a kidney bean or something right at the opening of your vagina, and you're just trying to close and lift that up. You want to do it with that exhale. It's going to feel very light. So if we talk about Kegels, what I want you to realize is that a Kegel is not squeeze your muscles as hard as you can, for as long as you can, as much as you can, all day long. We see that advertised a lot, but a Kegel is really just the contraction of your pelvic floor. It can be slow, it can be fast, it can be held for a long time, or just for a few seconds. And all of these things are very important because remember, the pelvic floor is anticipating movement. So if we're doing yoga, how we use our pelvic floor might feel a little bit different than if we were going to CrossFit and doing box jumps or double unders. We need to know how to do slow contractions as well as quick contractions. And I think the best way to start this, like I said, is using that breath. But once you have that ability to use your breath, you want to build in other things, like using the pelvic floor with different activities. One other thing I want to mention is that in addition to learning how to contract the pelvic floor, we also need to know how to relax it. So what goes up must come down. It is very important that as we squeeze and lift, those muscles also learn how to let go. What we found is that a lot of pelvic floor dysfunction, it's not because the muscles are weak, but because they're overactive. So learning how to let these muscles go and let them relax after a contraction is going to be just as beneficial as learning how to squeeze and contract them. And these are the 2 minutes, great, thank you. All right, so phase 2, we've moved on. It's now about 6 weeks, give or take, and you've had your postnatal evaluation by your physical therapist, and you're ready to move on to more activities. This is where you're going to start to incorporate hip strengthening, such as maybe some glute exercises like squats and step ups, perhaps some leg lifts, or if you like to go to the gym and lift weights, TRX or body weight resisted movements. This is what you want to put into this phase. It is safe to go back to abdominal exercises, starting at a lower level and working your way up. I highly, highly, highly recommend that you are coordinating your pelvic floor into those muscle groups. So going back to that blow before you go analogy, before you start a set of exercises, take a second, think about your pelvic floor, do one breath, a full breath in, out, and contract your pelvic floor just to get it going. It's going to be enough so that your brain starts to remember, oh, this is how these muscles work together. They're automatic and they work before movement, so we need to retrain them to be automatic again. Some of the criteria to progress through these exercises include no leaking, no feelings of pelvic pressure, and pain-free. If you find that you're starting to go back to exercise and you notice some of these symptoms, this is another really good time to check in with your pelvic health physical therapist, because you may just need some more targeted interventions or maybe just some more feedback to make sure that your body's doing what it should be doing. Phase 3 is postnatal return to sport. And I wrote here the new normal because, like I said, while our bodies change, it doesn't mean they're broken. Just because we had a baby doesn't mean that we can't do high-level things. It may feel different than before, but it doesn't mean we're not capable. So I mentioned you could start strength training on average at 6 weeks, but you may want to wait until closer to 10 to 12 weeks to start with impact. So that includes jumping and running. It's important that we build a foundation and then build on top of that. So we would not build our house without a foundation, the same with our body. If our core is not strong and our core does not work well and can't respond to movement, we don't want to be doing things like higher level impact exercises. If you are going back to running, I highly recommend starting with a run-walk program, just so your body can get used to the running piece of that and slowly building up the endurance of these pelvic floor muscles as well. In this phase is also where we would want to add things in like plyometrics if you like to do box jumps or any kind of other jumping activity, things like tennis or CrossFit, etc. I would put those in this last phase. All right, and just as a reminder, like I said, these are the reasons why I do these things. What's great is when your kids get older, you get to run with them. So that's what we do a lot in our family now. And thank you very much for your time.
Thank you, Dr. Green. And we'll have a few moments for just a few questions. The first being, in patients who are very active prior to pregnancy, what is the goal for perceived level of exertion during exercise?
I'm happy to talk about that. So I have a 5-month-old, and I wouldn't consider myself an athlete, but I do like to exercise. And I also have a 4-year-old. Traditionally it was recommended, if you want to kind of have this range, that when you're exercising while pregnant, you shouldn't go over a heart rate over 140 beats per minute. But that's more recently started to change. They're kind of loosening up those guidelines because everyone has a different baseline, right? So 140 may be too much for another person, and 140 may be not as enduring for another person. Pregnancy and exercise can be a little bit confusing and frustrating, because in your first trimester, you may actually feel the worst because you have so many changes in your hormones as the fetus is starting to develop, but you may not look pregnant. And so you might be feeling a lot worse than you look. And it's kind of this dichotomy of, I should be able to do more. I don't look pregnant yet. But again, it does vary based on your prior athleticism. And again, you also have to take into account how you feel, and you can't neglect that just because you may look a certain way. I don't know if Blair or Lisa have anything else to add to that.
No, actually, I was going to say something similar. Really, with the heart rate, if pre-pregnancy your heart rate was something, then postpartum, I guess in terms of my talk, then that's kind of what you might aim for. But everything's different, and there's no specification like if you're pregnant you can't go over the certain amount. It really, from woman to woman, from athlete to athlete, from non-professional athlete to elite athlete, those ranges are going to be different.
Yeah, and even one pregnancy to another pregnancy in the same person may be completely different as well.
Great. And then our next question is, are there pelvic floor exercises that can be performed while pregnant?
Sure, so I'll take this one. Absolutely. I think just doing the Kegels like we talked about is one thing you can do. I think it's good to keep doing it as pregnancy progresses, because what you're going to find is that your muscles are going to change a little bit. So, but like I said, it's important that you can coordinate it with other activities. So if you are continuing to exercise, incorporating those pelvic floor muscle exercises into what you're already doing. So I would just focus on, if you wanted to isolate, maybe just doing 1 to 2 sets of 10 a day, and practice holding those muscles for up to 10 seconds. That seems to be the gold standard. And you can do that lying on your back. You can do that sitting or standing. So whatever's more comfortable or works for you. It's going to be a lot harder if you're doing them sitting and standing, because gravity is going to come into play there versus lying down. There's no gravity, so it's a little bit easier. You do have to be careful later in pregnancy about lying on your back for too long when you're exercising. So maybe as pregnancy progresses, you would want to try to do them sitting or standing. Another thing I really like is like if you sit on an exercise ball and you can use that ball to kind of, it gives you a little bit of feedback at what's called proprioception to the pelvic floor muscles. So when you sit on the ball, it kind of can help you activate those muscles a little bit better.
Great, thank you. And our final question is, what is the time frame a pregnant woman should stop working out and when they can safely start back after giving birth?
I can take this one too, unless one of you guys want to answer.
Go ahead. We're probably gonna have the same answer.
So what I recommend in terms of stopping, it's really personalized. I think people who are really active going into pregnancy can stay active through their entire pregnancy, probably until the day they deliver, if they're not in active labor and feel like they can. I think as time goes on, you probably want to modify a little bit. We talked about perceived exertion and that talk test. So I always use that as a guide in terms of cardiovascular activity. What you may find is that you're having to slow down a little bit, or do a little bit less, or maybe not lift as much weight, or change how you're doing things. I already mentioned the exercising on your back for long periods of time. So there's just some things to be aware of, but there's not really like a when you hit this phase in pregnancy, you need to stop. It's going to be your own personal comfort level and based on what you do. And I actually recommend that if it feels okay, you continue as long as you can. In terms of starting back, I think we did talk about that a little bit. Like I said, I think it needs to be graded. I think a good guideline is around the 4 to 6 week mark. That's about how long it's going to take your pelvic floor muscles to recover if you had a vaginal delivery, or if you had a C-section, how long it's going to take your body to recover from that surgery. So starting with lower level exercises, and then maybe around the 6 week mark, adding in some low impact cardiovascular stuff, like maybe cycling, swimming if it's okay to do that, and then some strength training, and then up to maybe the 3-month mark or so to add in the running and impact stuff.
Agree. And again, I 100% agree with, letting your body tell you, and a lot of people do exercise until their last day before they deliver. And in terms of starting back after delivering, I feel like Blair mentioned, doing the diaphragmatic breathing exercise. I think that's a great way to start back with exercises and just kind of training your pelvic floor to start getting stronger again, because your body's been through so much. And if you think about it, how quickly your body's been through, 9 months, 10 months is not a long time. And so starting slowly, even with just breathing exercise and then progressing up, is going to be important, because again, it's not a light switch where week 4 to 6 or week whatever you can go from nothing to everything. It has to be gradual.
Yeah, and I'll just go back, and what I talked about in my talk was relearning. If you have this time in your life where you've had a baby and now you can kind of back up and go, okay, now I can maybe relearn some training exercises because I had some bad training errors or whatever before. It's a good time to revamp and all.
Well, thank you so much to all of our speakers and to all of you for attending our pregnancy, postpartum, and pelvic floor session. I now invite you to head over to the link for room 1, where Mandy Blackman will be presenting implications for hypermobility for the female athlete. Is it possible to be too flexible? And after that session, we'll resume here in room 2 with our athletes in midlife and beyond. Thank you.
enjoy doing and hope to as we continue to go into our second half of life, if you will. But what I want to remind us as midlife women is that it's really important to remember that exercise and regular activity is really in and of itself something that research shows us provides a number of health benefits. And so sometimes there's some things that come along with midlife, including stress, having to travel more, not sleeping very well. And we want to make sure that we maintain that regular activity, because the activity can do a number of different things to promote our health. And at the same time, we need good nutrition on board. We need smart fueling to provide the nutrients to those different body parts, those different body functions, so that our body can continue to work properly and be the best we can be in midlife and beyond. And although that previous slide had a number of different nutrients, which I'm going to talk about some of those as we go forward, I really want to highlight that my focus with women is really on dietary patterns versus a single nutrient approach. We have a lot of data that show us that, you know, just one particular nutrient, if you study it, may not seem to have as positive effect compared to, say, a placebo. Yet on the other hand, when we look at dietary patterns like a Mediterranean dietary pattern, there's this synergistic and additive effect of nutrients and how they come together to work positively in the body. So something to keep in mind so that we don't get too focused on a single nutrient and potentially try to, what I say, out supplement or out train what maybe is a poor diet. So when we're thinking about that dietary pattern, we need to have balanced nutrition. So we have to have a balance of carbohydrates, protein, and fats. And this is just the number one question I get from most people these days, including midlife women, which is, so is it okay to eat carbohydrates? And I want to give you a resounding yes. Carbohydrates still are a preferred fuel source for the brain, among many other body functions. And so if we don't consume enough carbohydrates, we don't have enough carbohydrates on board, then we have where the body will really need to depend on other sources in the body, most notably lean tissues. And so this is why carbohydrates are thought of as a protein-sparing nutrient, so that our body can use the carbohydrates for energy and let the protein in our body be used for the repair and recovery that it needs. Carbohydrates are also required for anaerobic metabolism. So as this graph illustrates, you know, if you're doing kind of a regular moderate level of intensity, you know, you can kind of talk while you're running, for example, probably using a couple different fuel sources, fat and carbohydrate stores. But when we are, let's say, sprinting, or if you're cycling and you're climbing a hill, or some of our even anaerobic sports that people are involved in, sometimes even with tennis, you're going to need your body to depend on carbohydrates for fuel. And if you've consistently or chronically consumed a very low carbohydrate diet, our body has learned to downregulate that metabolism. And so you can have a little bit more fatigue when you're trying to do anaerobic metabolism, and consequently be at risk for injuries. Carbohydrates is also a key ingredient for a production of brain neurotransmitters. So some people have heard of serotonin, which we think of as the feel-good neurotransmitter, but that's a chemical in our brain that actually depends on carbohydrates for the production of that neurotransmitter. Carbohydrates are also really notable for providing important vitamins and minerals for the body, and you can see those listed here. So if for some reason you decide to remove dairy foods, then we have to look at, well, what are those calcium-rich foods that you're going to replace that food product with? Or whole grains. If you're thinking of taking out oats and bran, which a lot of time are in cereal, or any of those other foods, where are you going to, get good sources of B vitamins and some of those other nutrients? But probably what we're seeing more in the emerging research is really this, we've known this for decades, but fiber really has an important benefit of promoting a healthy gut. And the effect of a healthy gut microbiome, we're still really just learning about. But fiber ultimately comes from plant foods, which are carbohydrates. Excuse me. And then protein. And most people are pretty focused on protein because of some of the diet trends and fads that are out there. But nevertheless, protein really is important for helping maintain lean tissue, certainly for keeping a strong immune system. And for midlife women can sometimes be important when we consider helping to decrease and manage cravings. So how much is often, what we want to wonder about. So for active women, as we're aging, it's recommended for about 0.5 to 0.7 grams per pound per day. And so what that might mean is about 20 grams of protein at each meal and potentially after activity. And that would be something that is about the size of the palm of your hand, or 2 to 3 eggs, or a size of a deck of cards of fish. So this isn't a large amount of food, and it's not necessarily something you need to supplement. It's just more about the consistency. And there's a number of different food sources that provide good, high quality sources of protein that you can see there. But I want to highlight also soy foods, because soy has gotten a bad rap over time. And really, it is a high quality protein. It has many different important antioxidant and anti-inflammatory functions in the body. And it might have a role in menopause management, but what the literature will show us is that it depends on the individual, and if you have a certain type of intestinal bacteria that can break down those soy foods into something that may even potentially have an estrogenic effect. So if you're worried about soy having an estrogenic effect, oftentimes it probably isn't going to provide the benefit you think, but it's sometimes something to consider adding into the diet if you have decreasing estrogen and want to consider trying those foods. And then there's fat. And for those of us who are in our 50s, we are very familiar with the late 80s and early 90s mantra that was, if you eat fat, you're going to get fat, and you're going to get all these other diseases. And so we were part of the non-fat, low-fat generation. And so, we've really come to correct some of that data and re-emphasize that fat is essential. It is needed to absorb important fat-soluble vitamins. It provides flavor to food, which can help improve our satisfaction and the pleasure that we get from the foods that we eat. It allows for more food variety. And omega-3 fatty acids are certainly vital for many functions as it relates to cardiovascular health and mental health. And so really focusing on including a variety of healthy fats in our meals and snacks, avocados, nuts, seeds, fatty fish like salmon and tuna are all great examples to try to think about including more consistently. But then most women who come to me are really kind of wrestling with this quote, which is, I do all this exercise, I haven't changed anything, and I still can't lose weight. What is going on? And frankly, it's quite complex, because sometimes people really uber focus on the hormone changes, which that is part of it. We have fluctuating hormones happening in our mid to late 40s, and certainly as we go through perimenopause and the menopause transition. But what the research will show us is that when you control for those different stages of menopause, that it really seems that the weight gain is more likely associated with lifestyle changes. So potentially more stress, maybe not moving around as much, maybe traveling more, not sleeping very well, potentially. And coupled with that is sarcopenia, which is this natural loss of lean tissue as we age. And so those together can contribute to some unwanted weight gain. But a whole nother body of research, which I pay attention to, especially from the eating disorder field, is this effect of weight cycling. And so that is the situation where individuals have been going on and off diets over years, gaining and losing a bunch of different amounts of weight, and how the body becomes resistant to that weight loss, and how the body becomes actually protective. And so some of those symptoms, which you see in black here, hyperphagia is just referring to that increased drive to eat. And so some of those can actually be contributing factors to why, if someone is experiencing some more than usual or unwanted weight gain. So then which diet is best? We always have these really great meta-analyses that come out every now and then. And so this was a recent one that came out early this year. And this is quite an eye chart, but basically what it tells us, they had a majority of women and, around 49 years of age for the mean age. But the key takeaways, and this is not new, we see this in these types of analysis over time. But the key takeaways is that compared to a usual diet, most diets resulted in modest weight loss at 6 months. So basically you're making a behavior change. Whatever you choose in terms of that behavior change, it somehow can result in some weight loss. But the weight reduction at 12 months diminished, which again might speak to that protective role of the body, or maybe you're not sticking with that particular diet. But overall, when you compare these 14 popular different types of diets, the differences are typically small to trivial. And so really what we want to learn here is that if you really need to change your diet, probably focusing on foods that you enjoy, that are pleasurable, that is really something that is sustainable. So if you're not going to be able to sustain it over time, it's probably not going to work. And thus we have a diet industry with a 3% success rate and a 97% failure rate. So something to keep in mind. And one of the things I encourage people to think about, whether you're recommending extreme weight loss or thinking you need to lose a lot of weight or whatever might be a part of that, is what are the potential side effects? So just like we would look at side effects or consequences from a drug intervention or a pharmaceutical intervention, I really suggest we look at this from the weight loss standpoint. So this study took 100 postmenopausal women who were between the ages of 45 to 65 years of age, and they broke them up into two groups. So one group had a moderate intervention, was a food-based diet with a 25% basic energy restriction for a total of 12 months, so for a significant amount of time for that. And the other intervention was much more of a severe, very low calorie, total diet replacement intervention that they did for 4 months. They did supplement that with some whey protein and calcium and vitamin D to make sure that they weren't experiencing some of those nutrient deficiencies. But then after 4 months, they had them follow along with the moderate intervention, so for a total of a year. And what the researchers found is that, not surprising, in the severe intervention, at 4 months, they had lost more weight than the moderate intervention. But then after the 4 months, as they went back to the moderate intervention, you might see that there is a little bit of a weight change. We'll just call that stabilization. But what the researchers did that was interesting and something that's noteworthy for us to pay attention to is they looked at total hip bone mineral density, so bone density changes in that amount of time. And the top line shows our moderate intervention group, so there was some decline in bone density, but that the authors suggested would be what we would see for most postmenopausal women in that amount of time. However, in the severe intervention, there's much more of a sharp decline in bone mineral density. And on top of that, if you remember, they weren't losing weight anymore after 4 months, but their bone mineral density continued to decline. And so this was pretty concerning when you look at this type of data. And consequently, there was an increased incidence of osteopenia at 12 months among the severe group. So at baseline, 16% of the participants had osteopenia, whereas that increased quite significantly to 40%, whereas in the moderate intervention group, there wasn't much of a change from baseline. So when we think about dieting, which a lot of midlife women, for various reasons, are concerned about, sometimes it gets framed as wellness. I think the wellness word has basically been hijacked by our culture. But in general, dieting, or the effort to change the number on a piece of tin, there's a number of different methods we see, right? I mean, you might reduce your food intake or watch your calories, eliminate foods or food groups, or there's potentially forbidden foods that are rationalized as having some rules. And those rules and structure can be really helpful for some people. The rapid weight loss can maybe be motivating, or jumpstart, and it could decrease the risk of disease for some. So there might be some pros, but we really have to look at those cons. You know, it's hard to sustain for most people, often can result in loss of lean tissue, that poor long-term success rate, which again, then when we gain the weight back, we often see that we gain more weight back, and usually that can be shown up as visceral fat, which is more metabolically problematic, can lead to disordered eating, and can be harmful to athletic performance. So what should we do instead? So an anti-diet approach then is really focusing on our long-term health, all of those health objectives that I talked about up front. Really bringing it back to that, maybe working on improving your athletic performance. And how do we do that? It's through a number of different ways. Of course, focusing on diet quality, balancing those energy sources, which can help with the appetite management, some self-monitoring. Sometimes we have to address the body image concerns and maybe a loss of the thin ideal, which is easier said than done, but that can be some of the work that an individual might need to do. There's certainly some pros, long-term effectiveness, it's a focus on nutrient-dense foods, and then we can enjoy our food, and that's much more sustainable. But unfortunately, the results can be too slow for some.
2 minutes.
So some final words of wisdom then are, hopefully I've brought home the point of try to avoid restrictive diets. Eliminating food groups often results in nutrient deficiencies. So plan to eat during the most active time of day, ensuring an adequate intake of lean protein, including those nutrient-dense sources of carbohydrates might be more helpful. And remember that your body will adapt to whatever you do consistently, whether that's good or potentially bad. And remember, you can't out-train or out-supplement a bad diet. And that is my talk. Oops, I'm having a problem getting my...
Thank you, Val.
Yeah.
Our next speaker is Maggie Gebhardt, and she will be speaking on positive movement, staying active in the presence of pain.
Hello, I'm Maggie Gebhardt. I am a physical therapist with FitCore Physical Therapy. We're located on the west side of Atlanta, and it's an outpatient orthopedic clinic. I'm also an adjunct clinical professor with Mercer Physical Therapy in their entry-level and residency program. And I also do some contract work with Atlanta Dance Medicine, working with one of our keynote speakers, Mandy Blackman, as well as Emma Faulkner. Hold on, I just got a message that my camera isn't working. Let me pull it up. Sorry, guys. There we go. Sorry. Hopefully that's better. So just as I was saying, I'm a physical therapist with FitCore Physical Therapy located on the west side, and do some contract work with Mercer Physical Therapy, Atlanta Dance Medicine, and then also MyoPain seminars teaching dry needling across the US. So we're going to talk today about positive movement and the impact on it in chronic, or what I like to call persistent pain. So just quickly, I wanted to go into some of the changes we see in a aging athlete. Basically, we have contractile and non-contractile tissue. Some of our non-contractile tissue are bones, ligaments, and nerves. And then some of our contractile tissue are things like muscle and tendon. In connective tissue, you're going to see an overall dehydration and decreased elasticity of the tissue. That's going to make organs, blood vessels, and airways more rigid. In orthopedic world, I would like y'all to think about discs in the spinal cord or spinal canal, as well as meniscus in the knee. We often see those injuries as tissues get more dehydrated. But then also our ligaments are going to lose some elasticity because of this decreased dehydration. Bony wise, we're going to see a loss of mass. Bones become thinner and more likely to break with less trauma. And that's due to decreased calcium as well as other minerals. Joints are going to become stiffer and more rigid due to decreased fluid as well as cartilage breakdown. And then neurally, we're going to see a loss of cells and atrophy. As that breakdown happens, waste products can collect, and it's going to slow the transmission of impulses, which leads into our loss of, or our muscle-related changes. You're going to see lean body mass, and this decrease is partly caused by a loss of muscle tissue, atrophy. The speed and amount of muscle changes seem to be caused by genes. You'll have lipofuscin, which is an age-related pigment and fat that gets deposited in place of muscle tissue, and the muscle fibers are actually going to shrink. Muscle tissue is replaced more slowly, and lost muscle tissue may be replaced with scar tissue. Muscles are less able to contract because of these changes in the tissue, but also because of the neural changes I just mentioned as well. So you may see that the aging athlete is losing tone even though they're exercising consistently. And then as far as organs go, we're going to see that it's harder to restore equilibrium in the body. Drugs are removed more slowly, and there's going to be increased side effects. It's also going to be harder to come back from an injury or illness. And the most classic example I can think of is the comparison of a 50-year-old person recovering from a heart attack versus an 80-year-old. It's going to be much harder to recover for that 80-year-old. So there's many different theories about why aging happens, but the most prevalent theory right now is just a combination, and it can be a combination of heredity, environment, culture, diet, exercise, leisure, as well as past illnesses. It's very unique to the person, and we have no way of actually predicting it. What's interesting to note in the physical therapy world is that we see the highest incidence of herniated discs in people in their mid-30s. And that directly relates to that dehydration we just mentioned. So let's talk about pain. The big message here is that pain is normal. It is the response to what your brain judges to be a threatening situation. It is your body's alarm system. There's a great book I read in grad school called The Gift of Pain, and it's written by the physician who studied patients with leprosy. And his big premise is that pain is our body's main communication system. If we didn't have pain, the body would never be able to alert us that something's wrong. The interesting thing about pain, and where we're going to get into more of the persistent pain, is that when problems exist in the body, sometimes your brain will not perceive them, even if it's in danger. But vice versa, even if no problems exist, your body or tissues may still hurt because your brain thinks it's in danger. So the great example I like for this is to think about the wounded soldier in combat. They are not going to feel that intensity of pain as someone who maybe isn't in combat, because the brain perceives it's in danger and it can't attend to the pain right now because survival is so much more important. So we're going to get a little bit into how pain is actually generated. And this is an extremely complex topic. And I'm going to try to just give us the Cliff Note versions of this. So if you look at this picture in the upper right-hand corner of the screen, these are both what we call neurons. And neurons are the electrically excitable cells of the nervous system. And they transmit information to other nerve cells, muscles, glands, as well as the brain. So here in this picture, this is one neuron, the end of one neuron, and this is the end of another neuron. And this space right in here is called the synapse. And basically that's how the neurons convey messages from one to the next. It's the highway of our nervous system. So you have danger sensors located all over the body, and these sensors can respond to mechanical stimuli. They can respond to acidic stimuli, meaning chemical forces, as well as temperature. So when the danger sensors send enough information to the neuron to excite it, a message is sent to the spinal cord. So currently the message being sent, so if we talk about kind of going up this way, so here's our message coming up. And currently this message is just saying danger. It has not been interpreted as pain yet. The brain and spinal cord have to receive it and analyze these inputs and create meaningful experiences, which may or may not include pain. So then at the spinal cord, the message causes certain excitatory chemicals right through here to be released into that synapse where the neuron traveling up to the brain can actually receive them. So continuing along that, if you have enough danger chemicals in the synapse, then that neuron will get excited and then transmit the message up to the brain. And this graph kind of shows it. Here we've got just an accumulation of those chemicals starting to excite that neuron, and then it gets to a breaking point or the critical level of excitement. Once you get to this point, the message is going to be transmitted, which is up here. And then as the message gets transmitted, that excitation and those chemicals decrease. You can also have what we call a descending neuron, and that's the exact same thing, but it's coming down from the brain, and it can flood the synapse with chemicals and cause the synapse to be less excited and thus dampen those alarm signals. So basically, if we have a descending neuron coming down, it's going to release chemicals to prevent this message from reaching that all or none point. Some of these chemicals can be opioids, which we will talk about later, as well as serotonin and morphine. It's going to make positively charged particles leave the neuron, which is then going to decrease that excitability. So let's get into chronic, or what I like to call persistent pain. I struggle with the word chronic. I think it has a really negative connotation. And when I'm talking with my patients, I really like to label it more as persistent pain. And it's any pain that has been present beyond the appropriate healing time for the injured tissue, and it can be due to a number of reasons. It does occur less frequently with age, and we're going to talk about that in a second. But if pain has persisted for longer than tissues to heal, then increases in pain are far less likely to relate to changes in the state of tissues and more likely to be due to other threats. And we're looking at some of these threats over here in this cycle. So once those danger messenger nerves are sensitized, it really can be anything. Things that someone who isn't in persistent pain would think as positive. Going to work, driving, having sex. But then there's also some negative things that people may get caught in this cycle, such as fear of not being able to take care of their family, not being able to go to work because this pain has been unmitigated. So all of these threats that someone who isn't in persistent pain would be able to tolerate, and with someone who is, it's going to activate those danger messengers even more. So when I have patients, and especially patients who are aging in my clinic, I often hear that they say, well, it's just going to hurt because I'm old. And I really don't let them have that excuse. I firmly believe that aging and pain are not directly correlated. It's not inevitable, and there is no direct relationship. The prevalence of musculoskeletal pain generally declines with advancing age. And any pain we have is commonly thought to, or the big component of pain with aging is thought to be degenerative changes. And although arthritis can worsen with time, our research is showing us that it is not directly related to age-related activity level decreases. There's a study that identified factors that were protective against a decline in pain-related function. And these included good mental health, self-efficacy, social support, and greater activity, but not younger age, which I thought was interesting. So let's talk about the stages of tissue healing. This is very predictable. We know that no matter what tissues have been injured, a similar healing process is going to occur. The two main things that determine the speed of healing are tissue requirements and blood supply. So think of it, tissues with less blood supply, something like a ligament versus something with muscle, or that's an injury related to muscle. Muscle is going to heal much quicker than a ligament because it has more of those blood supply. So in the inflammatory phase, that's going to occur immediately after injury and extending about 4 days later. That's where you see the classic signs, if you think of a sprained ankle, the pain, the swelling, the redness, and the warmth. That's because you have pro-inflammatory chemicals flooding the area to help clean it, as well as to start healing the affected area. The proliferative or the repair phase occurs anywhere from 3 days to 6 weeks post-injury. Symptoms are going to vary greatly during this stage. It involves cells called fibroblasts, and that's what's really going to start to build our collagen and create new blood vessels. The remodeling phase can last anywhere from 6 weeks to up to maybe 2 years post-injury. And that's where the collagen is continuing to increase and the tissue is starting to contract and lay down along the injured area to make it match the original as much as possible. And here's a chart just to show when the healing process is occurring, but pain is being maintained, possibly due to those threats we already talked about. So in someone who doesn't have persistent pain, you're going to have this repairing of the tissue, and you'll notice that pain should diminish as the tissue heals, because the pain is there to protect the tissues. And if the tissues are healing, they no longer need protection. Pain actually often diminishes before the tissue even fully finishes healing. So in someone who has persistent pain, you've got the tissue that's healing, but the pain has actually been maintained up here due to some of those external factors. Once the healing time of the tissue has passed, the tissue doesn't get another chance. And so we're going to talk about some exercises in the various stages of the healing process, and that's really important to adhere to so we don't interrupt or alter that healing process. So in phase 1, and that's probably along the lines of the inflammatory phase, the goal is to reduce inflammation and pain. Hopefully everyone's heard of RICE, which is rest, ice, compression, and elevation. That's where this plays into things. A concept I really want to harp on is called active rest or active recovery. And it means that you still remain active without stressing the injured area. For example, doing an easy ride on a stationary bike while recovering from a rotator cuff surgery. It's important to carry this principle throughout the recovery process because you will need to give days off in between to allow for those tissues to recover. In phase 2, that's more of in our proliferative phase, the big thing to remember is that collagen is very new, and so it can be easily stretched or torn here. So caution should be taken to not progress too fast, so to not overly stress the tissue. In this phase, you're going to do some gentle stretching, some isometrics, which is strengthening without actually moving the joint through any type of motion. Passive range of motion, having someone help move the injured area to maintain mobility. And then progressing from gravity-reduced active range of motion to full range of motion. Gravity-reduced meaning you may be moving your leg along a bed, so gravity isn't tugging on you, versus standing and moving that leg kind of side to side where gravity is tugging on you. And in phase 3, which is our remodeling phase and beyond, that's return to sport. So it's going to need to be individualized depending on the activity you are returning to. You're going to move from concentric to eccentric exercises, doing more functional movements, plyometrics like jumping and agility skills, but really individualizing your strengthening to the specific activity you're trying to get back to. Big thing to remember for my athletes is that if you have had surgery, if you remember the tissue timeline, the healing timeline, you cannot return to the same level of activity right away. You have to remember that tissue has a tolerance and you don't want to push through it. Which brings us into some coping mechanisms I wanted to talk about. And this is where we really get into positive movement. So I use this term time and time again with my patients. We want that positive reinforcement. And so when you're exercising, you want to exercise or leave on a win. Some of the maladaptive coping mechanisms that I see in my patients with persistent pain is this boom or bust pattern. And that's really where they're just trying to push through pain. So the pain is present, but they push through it and they tolerate it as much as they can and try to ignore it, which is the boom. Then that pain becomes unbearable and you bust. You flood your nervous system with those danger chemicals and you leave yourself wiped out for days and weeks. It's more common in people who are perfectionists or high achievers, or people who perceive that other people or institutions are in control of their situation, which you often see when people are in persistent or maintained pain states. The activity level is going to keep dropping and eventually gets low because pain is now dominating, which you can see in this chart on the right. The next maladaptive coping mechanism is the no pain, no gain mentality. And I prefer to quote, no pain. You shouldn't push through like we just talked about. It's not helpful. And you should understand pain and know that some discomfort as you rehab is probably necessary, but not enough to leave you debilitated for days. The other maladaptive coping mechanism, and I know a lot of people may be interested by this, is to let pain be your guide. In a patient who has persistent or maintained pain, that's not necessarily a useful mechanism, because then they wouldn't do anything. They would be completely fearful of movement, and we would never be able to reintroduce activity without that fear of pain. So it may be helpful in acute situations, but really truly I encourage my patients to not give into it and be fearful, but to actually take control. Which leads into the first mechanism I really do like to support, which is to understand but not fear pain. And the big thing I try to coach people on is to learn that, or kind of repeat to themselves, when I am in pain, it doesn't necessarily mean I'm damaging myself. Recurrent pain doesn't necessarily mean you're re-injuring the same tissue. More that some cue has caused your brain to drum up a representation of that old injury. And then for all of my therapists on this call, the term motion is lotion is very common to all of them. Motion is essential for the health of all body systems. It is the main function most affected or controlled by pain. Our tissues are going to love activity. And so throughout the lifespan, with activity, muscles can be kept stronger, joints can move more freely, and tissues really can slide better.
2 minutes.
So this lecture focuses on how to get someone to progress through this pain cycle. And I remind my patients to be sore, not safe, which helps to reset this system. When your brain gets desperate to prevent you from damaging yourself, it really can do a lot of things such as nausea, vomiting, and fatigue. So we're going to pace and progress our patients through this activity level so that they're not flaring up, but that they're doing things that the tissue is responding positively to. So here you can just see pre-injury, this is where their tissue tolerance is, and this is where they feel pain to protect their tissues. And after injury, it's lower. So we just want to work on progressing our patients through without aggravating or stressing that tissue. Want to talk really quickly about the runner's high, and that's our opioid system that gets activated with exercise. And we talked about that descending chemical being opioids that help to mitigate mood and pain. And so when we exercise, we activate those descending chemicals, which helps to moderate those pain responses. Our big take-home message is that exercise can have a positive impact on pain. There is an increase in receptor occupancy in the brain after exercise. And when an opioid activates a receptor, it sends signals to your brain that controls feelings of reward and pain, which thus decreases pain sensitivity. Thank you. That was a lot in a very short amount of time. If you have any questions, my email is there at the top.
Thank you, Maggie. And our next speaker is Emily Bolthouse, presenting on hip health, gluteal tendinopathy in the mature athlete. And I encourage you to continue asking your questions through the Q&A function, and we'll discuss them at the end with all of our panelists.
All right, good morning, everybody. I am going to share my screen and get started. Okay. So I'm going to talk to you a little bit this morning about gluteal tendinopathy. Again, my name is Emily Bolthouse. I work at Emory Sports Medicine here in Atlanta, and we see a lot of patients that are dealing with these kind of symptoms. So it's familiar to me and hopefully can help anybody out there who's dealing with something like this. So we're going to start off talking about just a few definitions to answer this question. What is gluteal tendinopathy? Any tendinopathy is a tendon disorder abnormality that causes pain. This particular term is colloquially synonymous with tendinitis, which might be more familiar to you guys. And in the case of glutes or the buttock muscles, the tendon problem presents itself as outer or what we call lateral hip pain. So in this kind of circle area right here. For a long time, pain in this region was attributed to a bursa, which is a fluid-filled sac in the same area and called trochanteric bursitis, but there's some emerging research suggesting that gluteal tendinopathy is more likely the most common cause of this outer hip pain. And it's usually caused by too much compression to the tendons. So tendons can hurt for a number of reasons, including that compression, but also too much stress, muscular weakness, and overuse. And so here's a quick overview of the muscles that we are talking about. You can see on the left, this is a view from behind. You can see the glute max muscle, that's the big one, and the glute medius muscle. Where those muscles turn white is where they're turning into a tendon that attaches to the bone. And that bone's shown on the right. Specifically, these muscles attach at the greater trochanter, which is up near the top. And if you stand up and put your hand like you're gonna put your hand in your pocket and then move it down just a little bit, if you rotate your toes in and out, you can feel your greater trochanter sort of roll around under your hand. That's exactly where these muscles come in and attach. And there's also a glute minimus muscle, which is in the middle, and that's the smallest of the three. So who gets this? This condition is generally affects inactive people, but it can also affect athletes, which is why we're talking about it today, but especially runners. We'll discuss the reasons that each of these populations get it. They're a little bit different over the next few slides. It affects women more than men at about a 3-to-1 ratio, and it's most common in the 4th to 6th decades of life, where 1 in 4 females over 50 will be affected, so it's fairly common. Okay, tendinopathy is always caused, like I said, by a mismatch between the load that the tendon can handle and the load that's being placed on it, meaning too much load causes pathology or problems in the tendon and pain for the patient. So typically increased stress comes from both load on and compression on that tendon, like we talked about earlier. Overloaded tendons can be caused by weakness in the glute muscles. Glute weakness is really common for a few reasons. The first is that it's common in runners who typically have a lot of straightforward motion, very strong quads. They don't do a lot of lateral motion, and so these stabilizing glute muscles are sometimes neglected. And glutes also get weak if you sit a lot, which is basically everybody now who works at a computer, and your glutes are in a lengthened position, and so they get weak for that reason. Excessive weight and our rapid weight gain can increase load on tendons, since our hips and pelvis support a lot of our body weight. And I put a question mark by the last no anatomy differences. I couldn't find studies that substantiated these thoughts exactly, but they're commonly cited as hypotheses. And that's that women in general have wider pelvises, smaller tendon insertions, and hormonal differences that might explain the discrepancy and why it's so much more common in women than in men. So some signs that you might be dealing with this kind of pain. Signs in the inactive population, they might notice pain at the outer hip, especially the greater trochanter that we found earlier, and any activity that compresses this area, so sleeping or lying on that side, sitting with knees together, legs crossed, and standing with all of your weight on one side like this girl's doing, which is really common in women. Athletes tend to get it for different reasons, and those are usually training errors. So some problems with training load that can predispose you to glute tendinopathy are listed here. Increasing mileage too much and too quickly can cause a whole host of problems, but definitely hip pain. Not allowing adequate recovery time, which, as some of the other presenters have talked about, we need more of as we age. Running on a cambered or sloped road. In that bottom picture, you can see how the road is sloped, so one foot is always hitting a little bit higher. That can cause hip problems on one or both sides. And walking or running always the same direction around a track for the same reason. Increased hill training, up and down, and then running with poor mechanics, specifically if your feet cross midline, like this girl on the right here. She's crossing over, and that's causing compression and stress on her outer hip pain, and that can sometimes be caused by glute weakness. This condition is usually diagnosed by your doctor or therapist just by listening to your symptoms in the office. They ask questions about how they started, what makes them better or worse, and by watching you move in combination with some specific movements and tests. It usually does not require advanced imaging, so x-rays or MRIs initially, and they save that usually for if there's something more intense going on, like a tear, or if you've failed conservative treatment So it's definitely not the first line of defense, not always necessary. Okay, so now that you know if you're dealing with it, how can you manage it? You'll notice that the top two options here I've bolded and made bigger. I did that because the great majority of tendinopathies can be treated conservatively with these two strategies, which are load management and tendon rehab, which we're going to break down and go over in the next few slides. If someone fails conservative management, then injections or surgery might be considered, but it's also important to point out that tendon healing can be pretty slow, so you have to be patient with the rehab and give yourself a good chance to be successful with that first. So the first step is load management, which means decreasing the compressive load on the tendon. So the first things to consider are easy to implement, and it's just positional adjustments. So if you have glute tendon problems, here's a list of positions you should avoid. Sitting with your legs crossed or your knees together, standing like that girl a couple slides ago, and lying on the painful side. I highlighted the last one because it's a little counterintuitive. I think even being a therapist and learning a lot about tendon rehab throughout my career, it's counterintuitive to avoid stretching when you have an injury or trying to avoid one, because it's really pounded into your head that stretching and flexibility is really important. But especially in this case, stretching is just going to put more stress on the already stressed tendon. So we want to avoid adduction or crossing midline stretches. So any stretch where you're pulling your leg across midline is off limits while this remains painful. And here's just a few examples of these. They might look familiar: the figure 4 stretching or IT band stretching. All of these are pretty common, and they're just going to compress more on that outer hip. So you want to avoid these at least temporarily. Getting comfortable enough to sleep is really important, and this can be painful at night. So a few strategies that can help with this are sleeping on the non-painful side, like we discussed, but also using a pillow to help take the stress off the tendon. So if you sleep on your side, you would sleep on your non-painful side with a pillow between your knees. If you sleep on your back, a pillow under your knees. And if you sleep on your stomach, a pillow under your hips, all help to offload that tendon. So training considerations for load management if you're an athlete, these are modifications to make temporarily while you are symptomatic. So decreasing distance, you should be running pain-free distances only if you're having this sort of pain, and you may need to switch to walking or cross-training if there's no distance that you can complete without pain. Increasing the number of rest days, so taking a day off between each run to assess your symptoms and your pain. Hill training and plyometric or jumping training should be temporarily stopped. You also want to consider the surface on which you're running. So if you're running on a cambered road, like in the picture, or on a track, you want to try to switch those surfaces out totally or partially and switch directions on the track, which is generally accepted if you move to the outside of the track. You might also want to consider gait analysis, which could be performed by a clinician in the office, usually on a treadmill. There's also some mostly anecdotal evidence that ice can be helpful. It's not going to hurt anything. So I usually tell people, try it for 15 minutes or so, once or twice a day for a week. And if it's helpful, great. And if it's not, then don't spend your time doing that. But keep in mind that you also might have to take a small duration of time off of running if you can't manage the symptoms with these recommendations without increasing your pain. You can also try a couple of techniques to adjust your gait that can decrease force on the tendon as well. A shorter stride and an increased step count work together to decrease forces through the leg thought to occur with overstriding, like this guy's doing in the picture here. You can increase your stride, your step count, and decrease your stride with a metronome app. It's usually easier to do on a treadmill because you're staying at a consistent speed and increasing your step count. Another thing that's fairly easy to implement is just running with a slower pace to decrease the load. And lastly, if you do have a crossover gait pattern, you can try to widen your base slightly. And it shouldn't be super wide like you just got off a horse, but like just enough that your feet aren't crossing over a midline. So use a lane marking like for a bike path or something, and just watch your feet for 10 seconds or so and try to widen them. It's really important that any gait changes you make, you do really gradually over time, because if you do too much too fast to change your gait, you're going to end up overloading other tissues and have other problems. So you can get more guidance from a doctor or a therapist if you think your gait is contributing, for sure. Okay, so now that we've modified the load on the tendon both positionally throughout the day and during your running or your training, what can you do to start to rehab the tendon itself and get it ready to return to your sport? Tendon rehab is generally prescribed in 3 phases. So we'll break each of these down by isometric exercise first, isotonic exercise, and then return to sport. Isometrics are the first phase of tendon rehab. And isometric literally means same length. So the muscle is working, but nothing is moving. So you can picture trying to move a weight that's too heavy for you. Your muscles are working, but the weight's not moving. A lot of recent research has been done in this area, and there are good results coming out of the studies about the isometric contractions regarding tendon rehab, especially in the reactive or the painful early stages of this. They have been found to decrease pain signals from the brain both immediately and immediately after the exercise and up to 8 hours following, which is, I think, pretty impressive. The contractions have to be against fairly strong resistance to get the effect. And 5 repetitions of 45 seconds was found effective in a study, but we still don't know what the exact perfect duration is, but that's a good place to start. And I'm sure further studies will further define this for us. So some examples of isometric exercises that you can be doing are here. Using resistance bands, which are readily available. You can get them on Amazon or a lot of the exercise sections of stores. The first one here on the left we call a supine clamshell exercise. So remember, these are supposed to be isometric. So you push your knees out wide against fairly heavy resistance with a band, and then you hold that contraction for 45 seconds. The most recent study I read suggested a 2-minute rest period between reps, which seems very long, but that's what they did and it worked. So I would suggest that, and then completing 5 reps total. The next version, this exercise on the right, is really similar, except you're standing. And they called this one imaginary splits. So the band is around your knees and you're trying to activate the muscles like you're going to do the splits, but again, you're not moving. So it's also important with all of these to remember you need to sort of ramp up to that strong contraction. So you start squeezing a little bit and then squeeze up to a max isometric contraction and do the same thing coming back off. So you're not just slamming into strong contractions. These 2 are working your hip abductors or your glute medius muscle. We also don't want to forget about the glute max. So this next exercise here on the left, again, targets hip extension, and the glute max, it's called a hip bridge. There are several progressions that can be completed isometrically, but this one's basic. You push through your heels, lift your hips up, and then hold that again. We also don't want to neglect what we call functional training or exercises more like running, so standing exercises. Double leg, quarter squats, just holding that with proper mechanics can be used in this phase. And then lastly, on the right here, this guy's just doing single leg balancing. So with arm support if you need it, trying to make sure that your pelvis is staying level and your single leg that you're standing on is in good alignment. So typically, these exercises are completed for 1 or 2 weeks before progressing to the next phase, but every patient is a little different. So you want to use symptom assessment to guide your progression, and pain should be significantly decreased from baseline before you move on. How do you know if you're doing too much, not enough, or just enough? It takes some trial and error, but a couple easy criteria you can use is if you notice an increase in morning stiffness or an increase in pain at night, you're doing too much. If there's no change, you're not doing enough. And if you can notice a decrease in your pain at night, then you're doing just enough and you're on track. All right, the next phase of tendon rehab is isotonic contraction, meaning generating muscle force by changing the length of the muscle. And most familiar exercises that people think about are isotonic exercises. You can start this phase when your pain has decreased appreciably, when sleeping is more comfortable, and you're generally pain-free with daily activities. These exercises should be completed about 3 times a week with rest days between sessions, and you can keep doing your isometric program as a warm-up. And you want to keep avoiding compression, so keep avoiding those positions that we talked about earlier. These particular exercises are recommended for this phase from a really good study in 2018 called the LEAP trial, which concluded that education and exercise was superior both to injection and no treatment, obviously, in reducing glute tendinopathy pain. They have really good descriptions of these, and it's readily available online, so I can send the link to anyone who's interested. These were studied, but it's important to know that there are hundreds of exercises that could be potentially appropriate here, depending on the patient, their activity level, and their chosen sport. So just a couple examples are single leg squats with attention to good alignment. So again, straight up and down in the standing leg and a level pelvis. Single leg squats here, and then step ups, very similar, stepping up onto a stair or an aerobic step. And a couple more. She's doing a slide out from the wall. So standing on her, it looks like her left leg, and then slowly sliding her right leg out against the band and back in to work those muscles isotonically, and then side steps with the resistance band either around your knees or around your ankles, which is a little tougher. The next and last phase is to continue working on building endurance and strength by increasing your sets, reps, resistance, and also progressively returning to running or walking or whatever your sport is. A few of the other presenters mentioned this, but it can be really tempting to jump right back in where you left off, especially if your pain is much better, but don't do this. You have to progressively load the tendon by adding a little distance at a time, adding a hill or two at a time. Otherwise, you're going to end up right back at the beginning and have to start all over. So avoid the temptation to just jump right back in where you left off. And a couple final thoughts that I think are important to wrap this up. The first being that you should expect this to take a couple of months at least, and potentially more time to resolve. Especially important to note that if it's been going on for a long time, the longer you've had symptoms, the longer it might take to recover. It's also important to note that just like in this picture, treatment plans and protocols always seem really straightforward, like do this for 2 weeks and then you'll feel better and you move on to the next phase. And it's all very linear and predictable. And that's almost never how it goes in real life. So don't be discouraged if you have setbacks, if it takes a little bit longer, if it's slow. Try to be flexible and adapt to your particular response to the exercise. And then lastly, if this seems overwhelming or if you think you need more guidance, you can always seek out the care of a clinician that can help. And here are my references. Thanks.
Thank you, Emily. And our final speaker for this session is Kate Walker, presenting on the benefits of weight training.
Okay. Hello, everybody. I am Kate Walker. I'm just getting ready to share my screen. Start my presentation. Let's go. Okay. So not sure why that started right there. So just to let you know, I don't have any disclosures. From my talk, I want you to be able to list 3 conditions weight training improves. How does weight training affect bone structure? And how much weight training should adults perform per week? Okay, those are just a couple things I want you to pick up from this talk. About me, I've been a PT for 17 years. I'm a former D1 softball player, and I was introduced to weight training myself by a really intense phys ed coach my freshman year. And I really believe that working out and lifting weights is vital to better function and better aging. So I love weight training. I do it myself routinely every week. So I'm a real big proponent of weight training. And just to let you know, I will probably use weight training, strength training, and resistance training interchangeably throughout this talk. It's all the same thing to me. So what is considered weight training? Weight training is any physical training or exercise that uses an external load for resistance. So your weight can be body weight, weight machines, or free weights. According to federal guidelines, adults should do muscle strengthening activities of moderate or greater intensity and that involve all major muscle groups on 2 or more days a week, as these activities provide additional benefits. And those activities, in addition to, with the additional health benefits, is in addition to aerobic exercise, okay? And that 2 or more days a week should be 2 non-consecutive days. And that means working out the glutes, working out the quads, working out the hamstrings, the pecs, all of the major muscle groups that we need to use to function in real life. Now, in addition to the 2 or more days a week of lifting, the federal guidelines also say that you should be getting 150 minutes to 300 minutes of moderate intensity activity of aerobic exercise, or 75 minutes to 150 minutes of high intensity aerobic exercise a week. So this is in addition to aerobic exercise. So why lift? You know, this picture of this older lady is lifting. Why lift? And hopefully that's going to be me in 40 years. I want to keep lifting like that. Now, the benefits of weight training: you improve your strength. That's a given. You improve your bone quality or your bone health, your cardiac functioning. You help reduce the risk of type 2 diabetes. You improve your cognitive and psychological status, and you help your dynamic balance. But remember, we don't have to be an Olympic weightlifter to get all these benefits. You can get them just by lifting smaller weights, and especially maybe starting out with somebody who knows what they're doing, okay, or how to help you get started. With the benefits of weightlifting, you also start getting improved sleep, increase your energy, more effective fat loss. You improve your muscle mass, which increases your caloric expenditure throughout the day. And you improve your overall body mass index, which your body mass index is a big not diagnostic, but it's a big tester of your kind of overall health, which it's kind of debatable whether it's really accurate or not sometimes. It's your muscle mass compared to your overall weight calculation. So strength improvement. How does your strength improve? So as we age, our muscle mass decreases much more in women than men. But as we lift, we recruit more muscle fibers, which improves our muscle recruitment. So our nervous system has to communicate with our muscles to tell the muscles to fire. So basically our brain has to say, move your arm with this weight in it. Our nervous system goes down, fires to the muscle contracts, and the weight is moved. And as we improve the muscle recruitment also improves neuromuscular communication. So kind of every time we lift, we continue to lay down new communication networks. So if we ever get hurt, if we get sick, we can, if we've been lifting, improve upon and call upon all of these networks to help us continue to be strong and continue to move and get back to our prior level of functioning faster. Just because we've laid down those networks and we have better muscle recruitment overall. Now, muscle hypertrophy increases the size of the muscle and assists with improved strength. So as we lift and as we get stronger, hypertrophy occurs. As we lift, micro tears, we have micro tears in the muscle itself. And when the muscle kind of tears, the body sends its own repair response to assist with healing. That's how we improve the strength of our muscle and get stronger overall. We lift, the muscle actually kind of tears, the body tries to repair itself, and that's how we get stronger. Okay, now we also improved bone density with weight training. Here's a little bit of background for people who don't necessarily know as to why weight training will help with bone mineral density. There are 2 kinds of cells in the bones. We have osteoblasts, which help build bone, and as we age, these decrease in production. But we also have osteoclasts, which break down bone, and as we age, these kind of stay steady. And you also have to remember that the femur that you're born with is not the femur that you end up with when you're 50, when you're 55, when you're 60. Our bones are constantly breaking down and being built up, breaking down, being built up. That's called remodeling, okay? So as they're getting broken down and building up, but you gotta remember as we age, the bones, the cells that are building up bone kind of slow down a little bit. The cells that are breaking down bone stay steady. So our net outcome is a decreased bone strength. Now, perimenopausal and postmenopausal women also have an increased activation of remodeling sites due to the reduction of estrogen, which results in a decrease of both trabecular and cortical bone. Now, trabecular bone is kind of the bone scaffolding inside the bone. The cortical bone is that hard outer shell of the bone that we think of, that's bone. The trabecular bone is the scaffolding within the bone, okay, that helps support the strength of the cortical bone as well. Now, bone mass in women after the age of 50 is only 2/3 that of men. So Here we are, we're starting with an initial lower bone mass. But as we age, as estrogen decreases, we have a higher resorption of bone that leads to a much higher rate of osteoporosis. Okay. All right, so how does weight training help increase that bone mineral density? Well, there's a thing in physiology that's called Wolff's Law. And essentially, it states that the load that you place on a bone is going to improve the bone strength. So any load that you place on a bone is going to improve the bone strength, which means that you need to be able to place strain on muscles, which return place load on bones. This helps the bone remodel and improve bone mineral density. In a research performed by Kussler et al., it was shown that there is a linear relationship with bone mineral density change and quantity of weight lifted during a 1-year study. Okay, so this was in comparison to a control group that only took calcium supplements. They did note that bone mineral density responded to more to certain exercises at the femoral trochanter than other. Now, what this means is that they had women lift a whole bunch of weight. The women who lifted the most amount of weight had greater improvements in bone mineral density change than women who lifted lesser weight and on down the line. And they had hugely important improved bone mineral density compared to just that took supplements. So as Val was talking about earlier, you can't out supplement your diet. It's true about bone health as well. You can't out supplement your bone mineral density. And the down below, with them responding to certain exercises at the femoral trochanter, this just displays the need to focus on specific sites and muscular attachments to improve on deficiencies noted on diagnostic tests and everything. Now, weight training also helps improve type 2 diabetes and cardiovascular disease. So resistance training is already known to increase muscle mass, reduce BMI, improve insulin sensitivity, and increase glucose transport. So in Sherome et al., women engaging in any strength training experience a reduced rate of type 2 diabetes of 30% after controlling for time spent in other activities and confounders. So essentially, all these women who were strength training, they kind of parceled that out of the strength training. So if you're gardening, if you're walking, if you're a lot of housework, they kind of took that out. And even with just the strength training, once you took all those other confounders out, you had a reduced rate of type 2 diabetes of 30%. That's huge. I mean, I would love to do that just to get an improved rate of type 2 diabetes. They also had a risk reduction of 17% for cardiovascular disease. And then when strength training and aerobic activity were performed together, additional risk reductions for both conditions equal a total reduction of 65%. And that's just with strength training. That's a huge decrease in these chronic conditions that are really prevalent in society these days. Now, how does muscle mass and insulin resistance kind of go hand in hand? Well, once again, as Val kind of talked about before, you need energy for your muscles to move. Your muscle is the primary tissue that contributes to whole body insulin-mediated glucose disposal. So like she said, you use that energy for your muscles to move. You're using that up, which helps with glucose disposal. She also mentioned sarcopenia. Sarcopenia is low muscle mass. So if you have low muscle mass, your body will decrease insulin sensitivity. If you have low muscle mass, your body will decrease insulin sensitivity. In Srikanthan et al., higher muscle mass relative to body size was associated with better insulin sensitivity and lower risk of pre-diabetes. In essence, if you build muscle, you're going to be healthy, you're going to improve that risk of type 2 diabetes just because your muscle mass is higher. And so throughout the day, it's consistently using that energy that's available, which are typically carbs. You're going to improve the glucose disposal. So balance improvement with weight training. In Marquise et al., 71 subjects were randomly assigned to either a resistance exercise group, an aerobic exercise group, or a control group. The resistance exercise group strength trained while aerobic exercise group only walked. And they found that the resistance exercise made an important contribution to improved static and dynamic balance improvements. So you need to be strong, you need to be able to catch yourself because our balance gets worse as we age. And if you're strong, you're going to be better able to correct and self-correct your balance inabilities, inadequacies. I also saw this other article that I read that they had their subjects only perform leg extensions and hamstring curls. So basically only working the quads and the hamstrings, and just those two exercises helped improve their balance as well. So overall, if you weight train, if you strength train, your balance is going to improve as well. Now, cognitive function. So Brownbill et al. Wanted to investigate the correlation between bone loss and cognitive decline due to possible decreased estrogen exposure. Now, cognitive decline has also been associated with various nutritional deficiencies such as potassium. In this study, lower cognitive function was associated with lower hip bone mineral density, probably because these women were sitting or more, weren't moving as much, weren't doing the normal everyday activities of daily living to kind of just as normal people do, and they definitely weren't lifting. So therefore, if you have a patient, if you know somebody who has a mild degree of cognitive impairment, it may be a marker for lower bone mineral density. What does that show? We need to make sure that all women are encouraged to weight train or at least lift or exercise to improve their bone mineral density health and overall well-being. Now, Harold et al. Performed a systematic review to provide an overview of resistance exercise-induced functional and or structural brain changes that are related to cognitive function. So they took a whole bunch of articles, read, did all the analysis and everything. They found a positive correlation between resistance training and functional brain changes, especially in the frontal lobe. So this improved, this accompanied by improvement in executive functions. And so executive functions, for people who aren't as well aware, are such things as attentional control, inhibitory control, working memory, and problem solving. Okay, so once again, you resistance train, you improve your overall cognitive ability, including that frontal lobe, which helps with your executive functionings. Also, they found that weight training led to lower white matter atrophy and lower white matter lesions. Again, another improvement of weight training, improved cognitive abilities, and improved brain function as well. Now, chronic diseases and exercise. According to Booth et al., the researchers looked at 35 chronic conditions and discerned what could improve within these conditions. Of those 35, just a few were obesity, type 2 diabetes, coronary heart disease, peripheral artery disease, hypertension, breast cancer, and bone fractures and falls. They didn't necessarily specify strength training, but they discussed physical activity versus physical inactivity. And they deemed physical inactivity as one important cause of most chronic diseases. I think we probably all know that. But it just, once again, shows that physical activity primarily prevents or delays chronic diseases. So we need to get out, we need to move, we need to lift. Hopefully that will improve, like I said before, the type 2 diabetes, coronary heart disease, hypertension, all these chronic diseases which are really prevalent in our society today. That's my talk. I went through that a little bit quicker than I thought. And I just like ending on this quote that exercise and temperance can preserve something of our strength in old age. In order to continue to be strong and be healthy women, healthy people, we need to continue to lift. We need to continue to move in order to preserve our strength to age gracefully. And here are my references.
Great, thank you, Kate. Now I will invite all of our speakers to turn on their cameras for a little bit of our panel discussion. So one of the first questions that came up was in regards to nutrition, what can you share about competitive masters endurance athletes who aren't looking to lose weight but are still interested in performance? Such as we hear about reducing sodium intake from a public health standpoint, but find many women reduce too much and show signs of low electrolyte levels during races.
Yeah, that's a great question, and certainly something that I see quite frequently, not only for females of all ages, as well as some of my male, more elite athletes. And it is kind of this confusion over, here's this, nutrition for healthy, preventing chronic disease. So we call that like our healthy eating. We have a lot of research in terms of even the government, right? We spend a lot of time figuring out how do we use nutrition to prevent chronic disease. But then we have this body of research, which is sports nutrition, which is all about how it's a practical science for fueling before, during, and after activity. And this is where that sodium gets lost, is certainly athletes need a balance of both. But too often a person's foundational diet even becomes deficient in sodium because they're, in a well-meaning perspective, trying to focus on their health, especially at this age. But absolutely, individualizing that in terms of their nutrition planning is important as we consider the sodium intake.
Great, thank you. And another question, I know we've started to get some responses in the chat, but if we can describe further physical tests to use to diagnose gluteal tendinopathy.
Okay, yeah, I did answer it a little bit, but it's good to talk about, I think. So usually just by asking the patients what about their symptoms, what makes it better and what makes it worse, you can get, like I said, most of the way there. If they've had changes in their training load, that's another clue. But I do like to use the Fader and Faber test. So at end range, hip motion, having pain, and all of these tests are trying to reproduce lateral hip pain. So single leg stance is one, another one, and then passive adduction, so bringing their leg passively across to reproduce pain, and resisted abduction, or like a glute med strength test, is usually pretty specific and can hopefully do that way.
Great. And then another question we began to discuss in the chat is the risk for hip tendinopathies as high for cyclists as it is for runners? And can we speak to other sports or athletic pursuits that have higher risk?
Yeah, this is another good question. And I don't know, most of this stuff, everything that I read when putting this together and that I've seen previously is mostly about runners or sedentary people, not a lot about cyclists. But I think for the same reasons that runners get it, because they do a lot of straightforward motion, not a lot of lateral motion, your glutes can get weak, which is one of the risk factors for glute tendinopathy. So it makes sense. I don't know why maybe it's not as studied in cyclists or other sports. I think a lot of sports where you move a lot laterally, so soccer or basketball where you're doing lateral motion, those glutes are a little more active and maybe aren't as neglected and weak, but it's definitely something that can come up. And again, it may be just due to the female to male differences in pelvis width and tendon insertion size that may put us more at risk, which would be then across the spectrum of all athletic pursuits. So it's a good question. It seems like it's mostly studied in runners and sedentary people. So hopefully maybe there will be more coming out in the future that can clue us into what other sports maybe are at risk.
Emily, if I may jump in, and I know that this is your talk and I have no research behind it, but I think that maybe with cyclists, or why it might be just looked into with runners, is because the pelvis moves and so the glutes are sitting there, trying to stabilize the pelvis. And in cyclists, you're on a stationary thing already. Your pelvis is fixed and you're not necessarily firing your glutes too much. With cyclists, it's more kind of hips, hamstrings, especially if you're quads, hamstrings, especially if you're clipped in. So maybe might be it. That's just my initial thought.
No, good.
Maggie, you got anything on that? Do you have any input on that, or you have any thoughts on that? Cyclists or runners, Maggie?
I actually tend to see it in both. I think cyclists become really restricted in their hip range of motion.
Yeah.
They don't spend enough time on self-care, and there's no way they're actually working on the biomechanics in a closed chain position off of the bike. So I actually do tend to see quite a bit of glute tendinopathy in my cyclists. Anecdotally, I agree there's not a ton of research on it, but I think it has to do with how restricted their hip mobility is and how anterior hip musculature-wise that they are, how dominant they are, tends to cause a lot of tension and torsion on that posterior glute area.
True, yeah.
Great. Our next question is, when training a female athlete in her late 50s, early 60s, which is more important, high reps and low weight, or low reps and high weight?
For me, I would say high reps, low weight. You want to make sure that you're going to be, I mean, that the low reps, high weight are more for building muscle. In order to get the lean muscle, you want the higher reps with the lower weight. So that's definitely what I would shoot for, especially if you're getting into weightlifting or strength training for the first time. You don't want to lead yourself to a risk for injury or further issues. So I would definitely go with the higher reps, lower weight.
Great. And then touching on another question we started to discuss in the chat, but if a female athlete is at low risk for stroke, such as having a normal BMI, no risky medications, doesn't smoke or use alcohol, would you consider estrogen replacement therapy for bone and muscle mass and for thermoregulation and endurance aerobic activity?
And I can hop in quick to, I mean, I'm a dietitian, I'm not a gynecologist. So, even when that question comes up for me, I definitely defer to your gynecologist to assess that with you. But from the menopause literature, what I can say is that it really depends on the athlete. So the age of the athlete, how many years they've been postmenopausal. So back in 2002, 2004, the Women's Health Initiative research came out and kind of had a big scare around hormone therapy. And now in recent years, the North American Menopause Society and the International Menopause Society basically have some position statements that says, there's probably this window of opportunity where it's actually cardioprotective. And even if you go back and look at that literature to this person's question, there is a chance that it could be very helpful, especially even delaying that bone loss. But it really needs to be carefully discussed with a person's physician and gynecologist in terms of considering a lot of other factors that come into that decision. And if the woman has a uterus and you're going to supplement or you're going to use estrogen therapy, it has to be balanced with progesterone. So, making sure that it's a, good FDA approved strategy, because I think some people can get into some problems with that.
Great. Well, thank you so much for everyone attending our Athletes in Midlife and Beyond. If we have any final questions, I do invite anyone to write them in. Otherwise, I'll give a few schedule updates in the meantime. So another keynote speaker will be occurring in room 1. That is our own Val Schonberg.
I'm going to take off.
To nutrition and the female athlete, fueling to promote health and prevent injury. Followed by that, all 3 rooms will have a break for lunch. And then after lunch, we'll resume with another keynote speaker in room 1. That will be Kate Edwards presenting athletic identity and finding joy outside of your sport. And after that, beginning at 1:30 p.m., we'll resume here in room 2 for our final panelist conversation on health considerations in sports medicine. Thank you all for your attendance.
Thank you.
Thank you.